losing coagulation factors. The third thing is the hemodilution. The old school of once the patient comes in, give him 2 liters of fluid. This is completely wrong. Completely wrong. And again, if somebody is sitting in a trauma room and a patient comes and he gives him like 2 liters immediately, give him a lot of fluid, tell him Dr. Wazan is telling you you're doing a bad thing to the patient. Do not give fluid blindly. It's not appropriate. It's a killer. You will kill patients. Okay. I have witnessed patients with their blood pink. I've seen it. Pink blood. Okay. Because of too much fluid. If you're losing blood, you need to take blood. So do not give fluid. It's a cause of a killer. And the last one is the acidosis. You remember the first slide? The acidosis itself, it will impair the coagulation. So these are the reasons for coagulation. Now, so as we have agreed, these are 3 killers. The 3 killers might cause each other. Lactate is important, prevent hypothermia and the coagulation. Look at these 4 factors and fix them. Don't allow them to happen. So this is the second point. Now, the last part of it, number 3, the point that I told you I will give you with is pain control. You remember my daughter when I told you she had the cut? Now, 10 years later, she's remembering this cut. There is very good evidence that pain is bad for the prognosis of the patient experience, they don't like it, they hate the hospital. We know many patients who's been to the hospitals, and when you ask them how was the hospital, they will tell you it's very bad. I was shouting of pain, nobody looked at me. And this is true by evidence. We did the research ourselves. We found less than 18%, imagine, out of 100 patients with major trauma, only 18 had good pain control. Imagine if this is, I'm not going to say your father or mother or daughter, if it is you who is in pain, do you want to be a chance of 1 every 5 you will receive pain control? This is not right. So this is why I put my third message is pain control. Now, pain control has 3 parts. Stop, treat, reassess. As simple as that. Stop, treat, reassess. Now, the stop part. So pain control, the first part is stop. Stop could be fractures, foreign bodies, manipulation, and emotional. So if you have a fracture, you need to reduce it. Okay, so if you have a broken arm, you have to reduce it. This will put away pain. So this is when we say stop pain. So it doesn't make sense that somebody is in pain, you give him pain medication, and his hand is fractured halfway. So first, stop the pain. First, fractures, foreign bodies. If you have an eyelash in your eye, it will be very irritating. So you need, if there is any foreign body, you need to take it away or control it. Apart from a stab wound, for example, a knife or so, this is a different story. However, if there is a foreign body that is irritating the patient, like a piece of glass that is under him, for example, in the trauma or so, you need to take away. The third thing is manipulation. Okay, let's move the patient. You take him up and down and move him back and forth. You push the trolley with all the movement. He's feeling pain. You need to be careful of this. You need to stop having pain. And the last one is the emotional. It's easy for us to say, no problem, you're okay. If somebody have crashed, he lost his family, he lost his kid, he lost his wife, for example, when driving, he lost his car, he will be crying of emotions. And these emotions will make the pain even worse. So you need to reassure, you need to talk to the family. This is part of our role to stop the pain. So this is the first thing, to stop the pain. The second thing is treat. So you could see here a big circle of opioid, okay, morphine or so. In trauma, and we're talking about real injury, only use the green circle. Other stuff are only like dressing on the cake. But the real food is opioid. One day, I will never forget this, Min al-Wadi, the old hospital before the new building. This was really a long time ago. I've seen with my own eyes a little girl who had a fracture femur and the bone is coming out, an open fracture, okay? It's an open dislocated fracture femur. And the doctor over there, he gave her only IM Voltaren. Imagine bone is protruding out and he's giving only Voltaren. It does not make sense. So let's agree that you need to control pain. Only use opioid. This is the first thing. Morphine, fentanyl, whatever. Any other thing is useless. If anyone is challenging you, give him my email and I will talk with him. Do not use anything but opioid. Anything else is nothing. Now, if you use paracetamol, which is IV Perfilgan or so, there is evidence, and instead of using 10 milligram of morphine, maybe you will use 8 or 7 morphine saving. So it's good to use combined, but you don't use paracetamol and Voltaren instead. No, you use opioid, and these are like, you have a cake, and these are the creams or the cherries on top of the cake. So you could use paracetamol, NSAID, ketamine, you could use it. Now, if you know how to use ketamine. Now, I put here general anesthesia and local anesthesia. This is the last phase of opioid. Local anesthesia, if you have an open wound or so, you can block before it. You can do regional block. This will be great. Okay, if you have a laceration, for example, in the lip, you can do a regional block here. This is great if you know how to do it. Now, the general anesthesia, I'll give you an example. I remember one case in Hajj. This was in 2010 here in Al-Noor. The guy, he was crushed. Both lower limb are crushed. Okay, he was a motorcyclist. What did we do in the emergency? We intubated him. Why? Simply because he will need a large amount of opioid to control his pain. He will develop the side effect of opioid. As simple as that. So general anesthesia is an option to control pain, especially if I know that this patient is going to OR, he will have lots of manipulation. I have a crush injury that I need to wash and scrub. It doesn't make sense that you tell him أصبر شوية. Never do that to patient, please. The patient should not feel pain. So again, either opioid or general anesthesia. You need to see that this patient has too many injuries. Okay, he's too much sick and he will need a lot of opioid. But then I will not be around with him. Then yes, you can induce general anesthesia. You can give him general anesthesia. Is that clear? I need you to really to grasp this. There is nothing called IV paracetamol in trauma alone. There is nothing called IM Voltaren in trauma. This is nonsense. It's not appropriate. You are bad to the patient. And if I'm the judge in a medical committee, believe me, I will make you pay for that. Okay. So this is the second part. So we agreed that we need to stop pain. Number 2 is treat pain. Number 3 is assess and reassess pain. Now, our problem is our medications have a timeline. Our patients stay in the department for a long time. So there is no point of giving one medication when the patient comes and you just disappear. You don't see him. So again, in our study, we found less than 5% of people, if I recall correctly, they have a reassessment. So imagine somebody comes with a fracture, you give him pain medication, and then after that, you forget him. You need to ask him again, what is your pain score? So you ask him in the beginning, what's your pain score? He will tell you 10. And this is something I teach my residents always, ask about pain score. You tell him, what's your pain score? He will tell you 10. Now you give him the medication, don't leave him. Come after 5 minutes, especially if it's opioid, IV, 5 minutes, time it. How do you feel? If he is not okay, you have to give him another medication. There's no point of waiting another 1 hour. Imagine I will leave you on your pain and agony for 1 hour. It's not fair. So assess and reassess and reassess. You have to reassess your patient. So stop pain, treat pain, and reassess your pain. You don't do it once. You will have to do it multiple times. So to wrap up this, I will just remind you of the 3 things that I want you to go with. The team dynamics, as we have agreed, there is something before. we have to simulate, we have to train, we have to do our checklist. There is something during the event, which is the situational awareness, the leadership, the closed loop communication. There is something after, which is the debriefing, which is very important. Emotional support is very well needed. These are the important things about point number one. Number two is the killer triad, which is acidosis, and all we agree all that it's the lactate that tells us about acidosis. We have to measure it, we have to remeasure it. It will monitor our progression. The second thing is the hypothermia. Remember, if you are taking a shower, you're out of your shower bath in your room, you will feel cold. So make sure that your patient is warm, your IV fluid is warm, and you cover your patient well. And the last thing is the coagulopathy. Make sure that you avoid any reason for coagulopathy. And we have said the four reasons of coagulopathy. The last and most important in trauma is pain management. It's the most critical part that is always forgotten in trauma. And this is why you will find the ATLS protocol. You will read all the rest of the information in the book. However, these information are very critical, and I feel that these are the most important piece. So pain control is very critical. We agreed that we have three parts. One, stop pain. Number two, treat pain. And number three, reassess your pain score. Going back to my daughter, if time comes back, I will never stable her at home. I will take her to my hospital and give her a local anesthesia. Thank you and have a good day. Let's see.
دكتورة. Yeah.
Let me say a few words about our next speaker, Mr. Abdulsalam Senami. Mr. Abdulsalam is a consultant pediatric emergency medicine, disaster medicine, and a member of DAMA, Disaster Medical Response Team, System of Care Lead Urgent Care in Cluster 1, Co-Chair of Urgent Care Network Health Holding Company, Head of Pediatric Emergency Unit in East Jeddah Hospital, Chairman Scientific Committee Pediatric Emergency Fellowship, and board. Welcome Dr. Abdulsalam to the stage. He will talk about the mass casualty incident.
السلام عليكم ورحمة الله وبركاته. الصوت واضح؟ يسعد صباحكم بكل خير. يمكن كويس في technical issue بس we have plan B إنه the people online they have maybe the access to the slides, and we did some action now during our support to IT that we might send the link to the audience and they can access the link to watch the slides while they are also listening to the speaker. So this is part of response to our action here or to the failure of communication. So we have some technical problem that might happen anytime in any place, either healthcare system or out the healthcare system. So we should have the plan B for anything. So كل عام وانتم بخير الجميع، ان شاء الله باذن الله يكون lecture لطيفة simple. Usually the disaster concept or the lecture have some difficult terminology, so we'll try to make it simple as much as you can. So you are sitting now in a room. You came in the morning with your coffee and sitting here with the nice weather. So I will ask you one question. Did you put any plan for you if you have anything now happen in this room? Did you know where's the exit door? Did you ask yourself, in case we have fire in this rooms, do you know who is leading this area? Do you know who will organize the team? Did you ask self about this one? Okay, so this is simple thing. Disaster plan is not only for hospital, could be in any place. Even the people now sitting at home, they should have plan in case if you have any disaster, la samah Allah. So this is simply in disaster management. Dr. Ahmed, he spoke about the trauma and the dynamic team, and we're gonna continue the same principle and the same concept of this dynamic team. So our objective today is, can you just move it there, please? Okay, so the mass management system need maybe 5 days, 6 days course, intensive course. Today, just overview the concept of disaster management and planning for this incidence, and just overview the incidence command system. Sure, everyone here in the hospital have experience in management drills, cardiolo, many times, especially in Hajj season. So maybe every day you are doing the same drills, concept, everything. So just highlight the incidence command system, and then we're going to talk about basic triage, disaster triage, how you're going to triage the patient in the scene, not the usual triage in the hospital. So there's difference between MCI triage and routine triage in the hospital. Next. Okay, so what's the definition of disaster? Simple thing. It's any event that overwhelmed your resources. So here we have some spaces. If we get more than now 15 attendee, they will be okay. So we don't have any issue now to cope with this 15 cases. So could be trauma, mass casualty, could be infectious, anything that disturb your resources called disaster. Okay. So need more than resources. This is the simple definition of disaster. So this is a disaster cycle. Here now we talk about some lecture. The hospital, they are doing many drills. So this is some preparedness to the Hajj season for any mass casualty. What about risk assessment? And this is maybe usually every year in Hajj, they are doing the hazard vulnerability assessment. It's called risk assessment, which will be maybe in Mustashfa Noor or any hospital, which is there any risk? Yeah, it could be fire, could be something else, could be mass casualty trauma or infectious disease. So you should put all this risk assessment, and you are doing your training, education, awareness about all this risk assessment. What about mitigation? Mitigation, let's say now fil Jamarat now, you know the way before years, now we put it as 1-2 way. So this is some mitigation plan to reduce, I mean, if the fatality or any problem in Hajj. So this is what's called mitigation. You should pre-event. You should do something to prepare for your Hajj. And this is prepared. What about response? This is response during the disaster impact. Recovery, don't forget the recovery, post-disaster. You should, demobilization and recovery is very important. So this is just mechanism of any disaster. Could be natural weather or any impact of man-made, bomb threat, and hospital. Could be fire here, internal disaster, or external disaster like trauma, stampede, or any hazmat. What about how can you respond to your disaster? Either internally to your hospital, so locally you can manage your cases without escalation of this response to the التجمع أو الكلاستر or the المديرية. So this is some level of activation, either internal hospital or التجمع الآن أو next المديرية أو national وزارة الصحة. Okay, so this is the way how you escalate the response of disaster response. So what's the mass casualty incidence? You have the resources here and you have the victims here. So now you have the balance. Now you can manage your patient. It's okay, fine. So if the victims more than resources, it's called mass casualty incidence. So It's event causing number of casualty large enough to disturb your resources. And nor if you have now more than 50 cases, I think it will disturb, or 100, it will disturb. So your hospital here, not like hospital in the peripheral. So they might just respond to 5 cases only maybe, while here you can respond to many cases. So this is the way how you define the MCI. What about disaster management operation? So it's anything, activity, you do it before and during the response and after attack of disaster. So this is the example of MCI. Could be maybe like stampede, happened here in Hajj, or car accident, fire, building collapse, or weather. So this is an example of MCI. So what's your goal here of management of disaster here? So you have mass casualty. Your goal is to decrease the mortality and morbidity, isn't it? By what? Triage. So you should be aware about disaster triage. This is very important thing. You know why? You want to do triage, not only in the hospital. Some of them, they are, I think, sending you to the mobile team. They are calling you for mobile team. Please come, we need 3 staff, either 1 physician, 2 nurses, or 2 physicians, 1 nurses. We have some incidents, let's say, in any place there. So most of the staff, they are going to the place and they don't know what's going on. What can I do? What's my role? So this is very important. You will go there. You should have a leader direct you to the place and some job description. You should know, and you are the medical personnel, either staff or physician. You should know how you triage the patient there on the scene before you are moving the patient to the hospital. So the way of this triage, or the problem of this triage, is different from routine triage. Routine triage, you are sitting in the triage room, and one by one, you are doing the vital sign, and you categorize your patient 3, 4, or 5. That's okay, fine. In the scene, chaos, and we have confusion, many mass casualty, and many things. So how you move this patient before this patient? Because you want to make sure this patient is stable to move to the hospital rather than to keep him while he is sick. So this is very important. So the primary goal is to do the greatest good for the greatest number. You have more than 1,000 in the scene. You do expect that you want to do the greatest good for greatest number. By what? By doing the triaging, moving the patient, coordinate all the response with the team. So you have the limited resources. So be careful when you are managing this disaster by how you limit your resources. You will focus on 1 patient and doing intubation and do everything. While you have more than 15 cases, you can manage them and you save them. So this is the way how you triage the patient, moving to the hospital, nearest hospital, far hospital, which one we can transfer, which one we will not transfer. So this is very important. So you identify the patient with the greatest chance of survival. So this is the way is very important. Which one, wallahi, we can move it to the hospital and we can save them. Is there any immediate intervention we can do it on the scene to protect the patient or not? So this is simply the incident management cycle. Usually what? You will be notified about disaster in the scene or in the hospital. Then you will activate your plan. Third thing, you will write your action plan. And then recovery after disaster. So ask yourself every day, whom we will contact, who will activate the plan. Do we have hospital plan? Yes, we have hospital plan, sure. And unfortunately, it's called paper plan syndrome. So easy, they put the plan there, and just only maybe every year they are. No, please be aware about your plan. Usually, all the plan in the hospital, many file like this. Make it simple, flexible to the staff, and applicable. And practice. And this is very important thing. يعني احنا بناخذ example. يعني if you have it real, you take it easy. Don't take it easy. This is part of your education. This is part of your learning. Action plan, you should know what's your objective. Let's say now you are receiving many patients from outside now, cardiology. So the leader in the hospital, they should write the objective, clear objective. What's my plan here now? How can I direct all this objective to other staff to carry on this objective? So what about incidents? Could be simple or complex. So you might activate some of the ICS structure, or some maybe during the complex incidents, you might activate command system, branch, division, all stuff on the ICS. So this is RTA, it's limited risk. Maybe you will activate or not. This. What about the other incidents? You might activate ICS. So ask yourself, would this one will activate your plan? I contacted home. What about, what's my priority now to managing my NCI? Who is in charge now to activate the plan? Do we have ICS system in the hospital or not? So let's start by the cycle. So we have notification now, either external or internal. So this is the stampede, external. And this is maybe in Jazan fire in the hospital. So all happen in our hospital or something. So when you respond to the emergency, you should know, you should ask yourself, now you receive the call from Idar Tawari or someone. And let's say you are admin on call and you receive the call, we have, let's say, trauma outside, maybe 3 car, 4 car, we have more than 20 cases coming to your hospital. So what question you should ask the dispatch? Okay, so you should know what's the type of incidents. Is there any chemicals or not, or just only trauma? And then where is the location of incidents? What about if you have one nearby here 5 minutes, or you have more than 1 hour or 30 minutes? So this is will give you a chance to prepare your ER, your hospital for this incidents. Number of injuries. What about if they did some special action? So if you have, let's say, a chemical outside, civil defense, they will do some decontamination. But what about if you have this chemical 5 minutes from your hospital? So simply you have here a decontamination room, simply, because many patients may be coming walk in, not by ambulance. So you should prepare yourself, you should prepare your tent, you should prepare your area for decontamination. And what is the estimate time of arrival? So this is, I mean, simple thing, Codiolo alert or Codiolo. So this is the same when they are moving the patient. It's called ELO. What about staff action? Most of you staff working in AR on the hospital or in other department, what's your action now when you are listening or you are hearing this incidents? You should be aware about your emergency operation plan. Okay? You should protect yourself and you should activate the hex with the leaders. So you should ask yourself, do you think as a leader here in the hospital or anything, what's the likely impact of this incident in our hospital? If you receive 15 cases, for you, maybe it's okay, fine. We can manage. If you do expect many casualty coming, so you should prepare myself. You should call the staff. You should review your plan, write your objective, the operation period of disaster response. Maybe take 1 hour, 2 hours, or maybe extend to 24 hours or 48 hours. So you should plan all these kind of stuff during the disaster management. So decision maker during the either CO or CMO or admin on call, maybe the ER consultant or nursing supervisor or anyone. He can lead the incidents, especially after working hours. So please, you should be aware about your emergency plan. So how you prepare your hospital during the mass casualty incidents? So simple thing, if you are working in ER or in the hospital, you take some special preparation, and you should know how can we prepare our hospital. So every time you should protect yourself and your staff, PPE, and wear all these kind of protection. You stop all the elective activity. Sometimes you have elective surgery or you have cases like simple cases. You should stop all these kind of seeing patient, and you try to prepare your ER by doing round for all hospital and discharge the stable patient. So you discharge the patient, you don't know where they will discharge. Maybe some of the family, they are away from the hospital. They cannot come into the hospital. You should assign one of your area for discharging patient, boarding patient. So it's easy to discharge, but where you will shift the patient, you don't know where's the place. You should do it in your plan. Where can I push the patient to this area while they are waiting for their family? Okay, and you discharge you admit the admitted patient. And this is simple thing. You have experience enough to do that. So this is simple definition of what's called surge capacity plan in the disaster management. It's easy. This is conventional capacity. This is usual day or daily operation. So you have maybe now 15 beds in the medical ward or any place. Simply, you will shift all the patients in ER, the medical case in the medical area and the surgical. So this is the space or the beds. It's occupied by staff, occupied by physician, and by all supply. What about if you want to escalate this response? You have many patients. It's called contingency capacity. So this place, maybe it's not usually seeing patient in this place. You should provide a care that functioning equivalent to usual patient care. So give me example. Give me example of this plan B. Is there any plan for you here? So you have the daily beds, okay, fine. Do you have another recovery room, maybe? Procedure room, maybe. Sometimes you put him in radiology department or something. You can provide the care for them. What about the crisis? Yes. What about the crisis? You can put some of the patient here, and you assign some physician, nurses, simple to take care about this patient. So this is the way how you escalate your plan from normal daily operation, and then you put them in unusual place, but you can provide care for them. And this is the standard crisis of standard care, sometimes it's called, and then you put the patient there and you can provide care. So you can double the room, the beds in the rooms, and you can, some of them, if you have critical cases, you can shift. Let's say you have 10 beds in medical, you can bring portable ventilator, and then you can shift you admit some of the ICU cases to this ward. So this is the way how you think during the mass casualty incident. If you don't have this plan or kind of objective during the disaster, you will be in trouble. You will be chaos. You cannot think more than this one. So please practice this kind of surge capacity plan during the any drills with the leaders. So this is again what I said before. Level 1, vacant staff, equipped beds, empty, you can put the patient. Level 2, you have there is beds, but you don't have staff. Usually you have shortage in staff. So what you will do, you will put this patient in the bed, even you don't have staff, and then you can increase the ratio of nurse and physician to the patient. So you want to do the greatest good for greatest number. So this is the goals of disaster management. Okay. Do you know where is the hospital command? Ask yourself, where is our hospital command room before any incident happens? Not only the leaders, everyone. Where is our command system? Okay. So what about the system of hospital command? I think in the Hajj, all the people talking about ICS, command system, operation, logistic, everything, and wearing the vest and doing the drills. It's okay, fine to know this terminology, very important. The aim of that is coordinate the response, to be on one language, speaking the same plan to prevent any failure. So this is the incident command system. There is some sections, chief, operation, planning, logistic. I don't want to go just in detail to explain what is the role of each one, but this is symbol of ICS. Sure, you are hearing this before. So you should know your role. Follow the chain of command is very important during the disaster, and refer media to the supervisor. Don't speak about anything. The public information, they should speak about this kind of response. And then this is some role, the operation, the command, they will put the objective. That's it. So the operation is the one running this objective with tactical and doing some strategy to achieve this objective with the operation period time. Logistic, they are the ones supporting all kind of stuff during the disaster management, and planning, the one is just giving your plan, helping collecting the data during the disaster, all kind of beds, supply, everything, and then they will escalate to the command to add more objective and to increase more operation time. So you can activate just only 5 or 6 according to the disaster response. You can divide to the either branching, division, and you activate many roles during response. What about action plan? You have now the mass casualty incidents, many casualty coming to the hospital or any place. So what's your objective now? Okay, so you will assess your situation here, as mentioned by Dr. Razan. So you should awareness, situation, and then operation period. Some of the incidents will happen within 2 hours, 3 hours, 6 hours, 5 hours. So each period, you should put your objective, and the planning section chief, he should plan for this, all this operation period. What about strategy? You should define your resources. What can I do here now? What are the resources will help me during this response? And every time you reassess and you write objective, all these, the disaster response is flexible, simple. It's not complicated. Just put your objective and you can follow this objective. Don't ask in disaster, how can I do? You put who will do, that's it. So the people, they will do this objective, carry this objective. How can we do? We should prepare from now. How can we do? In disaster, don't ask you how you do it. Okay? Yes. So type location is very important. Life saving. Your clear objective, big objective to stabilize this incidence. Okay? To decrease mortality, to decrease morbidity. So this is the big objective. How can we do it? You put the operation period, he should do some tactical or strategy plan, either by increase the staffing, resources, transfer patient, discharge patient, all this kind of plan. This is the operation chief. So you receive now the notification, the size, complex of the incidents. It's simple, I can manage, or we need support from other healthcare or from national maybe. What about you need some private sector to help you, or other hospital to discharge the patient, to transfer the patient to them? You should think about that. And then how can we do some special concern in disaster? Operation, situation, very important. Already we spoke about that. So this is from, I think it's happened, this is from emergency response team or إدارة طوارئ الأزمات موجودة في كل hospital. It's happened this frame. So this is simple thing. You have it for, you should write the time of reporting, location, number of expected casualty coming to your hospital, type of hazard. So you see, put it in front of you and just fill it. Okay? It's easy for you to go back and then you review your plan. Maybe now you sit together as a team, you put your objective. Okay? That's fine. After 2 hours, there is more information coming to you. If you didn't write anything, you will forget the previous plan. Either you write it in the board, all thing, the planning section chief, they will write everything. Or you'll put it here in the paper. So every 2 hours, you might call the team, the HEX team, you will ask them, what can we do more? What can we do more? So what we did before and what we can do ahead. So this is just, you can write your objective here, okay? And then what's the action that met your objective? Who is the one responsible about that? Because as an incident command system or leader, this is the one responsible, and you should put the date and time. This is the aim of hospital command system, to coordinate all the work together and to follow the chain of command to prevent any chaos during disaster. What about the other thing? You can write here how many reds, how many yellow, how many green, how many blacks every time. Okay, we have hospital, we have scene, we have everything. هذه موجودة في كل المستشفيات إذا كان. Okay. Okay. So this is the overview of mass casualty. How can we respond? Now, further. Yeah. Yeah, this is the one we can speak now. Triaging. Yes. No, status routine triage. Disaster is something else. Now we will speak. هنتكلم عنها. It's okay, fine. Okay, good. So triage and disaster is not like routine triage. What's your aim in the triage? How you can prioritize your patient? How you can move this patient first? Okay. So simple thing. You want to sort all. This is the patient in the scene now. Now they call you, please. We have incidents. Let's say maybe 15 minutes away from the hospital. Mobile team A or mobile team B, what it's called. You will go with the ambulance and you find these victims. So how you triage them? Yes. So simple thing, you have primary triage and you have secondary triage, you have third triage or many triage. You know the difference between routine and triage. Here, many triage. Not like routine triage, only one single triage. So it's primary triage. Now you have victim. Which one you will move first? Let's say without color now. Okay, you don't know which can one we move it to the ambulance to the hospital. You don't know. So how can we sort these victims? Okay, so this is the way how you sort them. You put the red, you put the yellow, green, and dead, and this is the way how you transfer the patient. So simple thing, you transfer the red first, and then yellow, and then the green. We don't know, if you don't know the triage and how you tag them, you don't know how you this kind of criteria. Okay. So what's the step of triage and the C? Make sure don't enter if the area unsafe. Be careful. The safety officer there on the scene, you ask them, the area is safe or not? Second thing, you will search for the victims, where the victims, and then you apply the triage. Sorry. And then you report. Okay. This is what we apply, start triage. Simple, it's called start triage, simple, triage, and rapid, simple thing. So simple triage and rapid transport had a concept of start. If they will, you should apply start triage. What's triage? You want to move the patient fast by applying simple triage. Okay, shukran. So you will assess what? You will assess the respiration, cabin refill, and mental status. So this is the simple triage to move all these patients to the hospital to provide care. It will not take more than 60 seconds. Okay? So again, it's a dynamic. Fast, here safe, dynamic fast, and then you transfer all these victims. Back to the previous slide. You have now 15 victims. How you sort them as a primary? you will ask them, if you are able to walk, please go to this area. So most of them, if they can walk, green. So this is a primary just screening. If they cannot walk, just wave your hand. If they listen to you and wave their hand, that means it's yellow. If they cannot, that means either red or black. So at least you sort them, you push them to the area, which one, and maybe green, yellow, none, and then you will do some second triage by medical personnel, expert, to do some. And in this one, some of them, they will do immediate intervention. So maybe if you have hemorrhage, they will stop the hemorrhage. Maybe need some immediate intervention during this second triage. So this is the triage officer under operation, and we have triage team. So you know your role and follow the chain of command, refer to media. Okay. So من راح السين منكم? Did you respond to the scene? So what do you think? Yes. Red. Good. So, and another thing, you should divide your, yes, it's not only one place and moving. No, you have many places. You should establish the command post, because they are the leader there, Maidani, to direct all these people. They need leadership skills during this incidents. You know, confusion. Maybe some of the relatives coming to the incidents, and many media. So as a leader, you should lead this area by assigning place for you, either one command or unified command. Maybe let's say healthcare, civil defense, police, everything, because everyone has a role in this area. The hospital, they should, or the health system, they have role to triage, provide some care. The police, they have some role for evacuation of the road, organizing the area, civil defense, everything. Okay, what about, so here, incident command, transport, staging area for what? What's called for staging area? Maybe you need more ambulance. صح ولا لا؟ انت you are transferring هنا transport unit. Staging area for any ambulance, supply, let's say some medical intervention you needed, PPE. Assign this area for staging area for any supply coming. It's a matter of coordination. And think about that. And wallah, this area, I want to define, this is the scene. We have victims here. I should plan for this area. Here, let's say the command post there, transport. The other area is staging area to receive all the supply. And the other thing, the team who collect this patient. The other one, they are doing the triage. So it's kind of organization. So the incident command address the big picture by establishing all the strategy. You put some strategy. والله اللي موجود في السين, I will transfer the red to the nearest hospital to stabilize them. The yellow, I will transfer to other hospital. They can wait at least 1 hour, 2 hours, the yellow, and they can transfer. and the green, we can shift it somewhere, or we can give them some treatment, and that's it. Okay, what about the other transport? The maximize transport effort and consider another transportation. What about if you have now 15 green? Do you think we'll bring 15 ambulance? No. Think about the bus. So this is you will call the bus for transport green cases to the other place maybe, or you manage them. So this is the kind of planning during the incidents and a leadership skill. What about triage team? Receive the patient and direct them to the red, yellow, green treatment area. You have some, it's called advanced medical post on the scene. Sometimes you need to do some intervention to stabilize the patient before you move them to the hospital. But this is the team will provide some care to protect them. What about collecting or collection teams? They will collect all the patients and then will transfer them. A triage team also deploy in this one. Sorry. So this is the example of disaster area. You have what? Police, civil defense, EMT, volunteer, visitor. Here there is medical team. They will do some intervention. They will transport the patient either by ambulance, by bus to the hospital. Simple thing. So this is during that any disaster, you have some impact zone. Impact zone هذه shocked area وفيها death of victims. The other thing, it's confusion, many patients or confusion, and the other one is here, the external. So this is example of scene with RTA. You are going there to do some triage. So here, the command post, this is the restricted area. This is away. Why we are establishing this one? Media. Media coming to you. You should assign some area for media. That's it. Okay, خليك بعيد. Okay, fine. If we have some information, you will direct them to the one responsible to deliver the message. Yes. What about the refreshment area? You have psychological trauma. Maybe the visitor coming to you scared and everything. What about the staff? After triage, sometimes they need some psychological support. They need something. So this is the area for refreshment. Some volunteer will bring water, juice, many things. You will put it there. Okay. Here, the command post, holding point, collecting, and then you can do some intervention here, and then you transfer. So this is the way how you divide your place to triage the patient. Again, this is the same example. During the something different, we have some, it's called hot zone, warm zone, and cold zone. The people responsible in the scene, civil defense or something, they will direct you to which zone you will do it. So if the hot zone, you need to be more be wearing PPE and the level of PPE, and then you do triage, and then you do some intervention, and you transfer to the hospital. Okay, so this is start. We have some green, it's called minor injury, yellow, serious, but not life-threatening. Maybe they can wait up to 2 hours. And red, treatable, life-threatening, and black, did, and that's it. So this is the simple thing of 4 color coded in triage. What about if you have medical field or anything get infected during or getting injury during this response? You label him as red. So maybe one of the staff get injury, you label him as a tag red, and you transfer. Okay, because you need more resources, you need more supply or something. So this is the red triage, simple thing, immediate care, and casualty whose condition is critical, cannot wait, and this is the first priority for transportation of the scene to receive the care on arrival. So you do triage, primary sorting. Who can walk? Please come this area. Cannot walk, they can wave to this area, let's say. There is no response, either you triage red or black. Then you will do some, yes, you will treat some patient before you transport to the hospital. Then at the entrance of the hospital, you will do another triage. Okay? And then in the hospital, you treat, and then every time you assist your patients. Clear? And here the yellow, delay care, hospital, but can wait. And the green, okay, can wait for a long time. Okay, again. So this is the one before the routine. You have resources in the hospital. You're applying Canadian or what? You have time and you have training and triage once. What about disaster? Limited resources and then compressed time. You have just 60 seconds to decide with basic training and frequent re-evaluation. So maybe you have many triage in the scene, and then after that you treat, and then you transport to the hospital, and at the entrance of the hospital you will do more another triage. So here you are doing triage. Don't focus on one patient for a long time. Okay, so the chance of survival, you will do triage based on your greatest code for greatest number. Yes. So here, excessive care to the one patient may result in the failure to the care of the other patients. Okay. So how do you do basic assessment? You will assess the mental status by ask, what's your name? Squeeze my finger. What do you think if they have hearing impairment? You will do, put your finger and you squeeze them, he will do it. Okay, so by this way you assess what? The mental status. Okay, quickly. And then what about respiration? You can watch, I mean, the chest rising, and then you put your hand here to calculate for the respiratory rate, and then some of them need intervention opening the airway. So this is some intervention you can do it in the scene to protect the patient before you transfer to the hospital. What about the capillary or so what you will do here, you will assess the capillary fill, and then If more than 2 seconds or less than 2 seconds, what's the intervention? You can do it in the scene. You control the bleeding by what? Stop the hemorrhage. So this is some intervention you can do it. What about the pediatric hospital child? Again, sorry. You assist the respiration by chest rising, respiratory rate, and then you open the airway, and you can give him 5 breaths. Yes. Okay. So this is jump triage. The adult, it's called start triage, and this is jump triage. You assist the capillary fill here for the child, and then you see if more than 2 seconds or less than 2 seconds. تعبتك معايا اليوم. Okay. So, is the patient breathing? Yes or no? And then, if yes, you will calculate the respiratory rate. If more than 30, red. If less than 30, you will assist the capillary refill. And then more than 2 seconds, red. And less than 2 seconds, you assist the mental status by he can follow the command or not. If not, you will apply them as a red tag, and then here, if cannot follow the simple command, you will tag him with yellow. What about the other one? If there is no breathing, you open the airway. If there is no breathing, black. If breathing, red. So this is simple thing. Within 30 seconds, up to 60 seconds, you assist your patient before you transfer him to the advanced medical post. They can do some intervention to be transferred to the hospital. So if you triage them, red, green, yellow, you will transfer the red first, and then yellow, and this, and the last is the green. So here, again, red and yellow. What about the pediatric? And this is simple thing. Again, children again, open the airway, and then deliver 5 breaths for pediatric. So let's start by some simulation cases. Okay, it's simple thing. You apply it. So this is the adult female is walking toward you, doesn't know her name or what happened. So what you will do, you will assess the mental status, respiratory, and capillary fill. Okay. Respiratory 18, mental status, verbal. So tag him. Yeah. So what you will do? Red. Excellent. Okay. So it's simple action. You do it, and because you have another triage, huh? You have primary, secondary, third triage. Okay. So there's something in the mental status. So you label him as a red. 10 years old. لازم اجيب البيدياتريك معاه. Okay. Trauma to the abdomen. Assist the patient. So this is simple thing. Red. Okay. 7 years old who is not breathing. What's the action you do it in the? You open the airway and you give him breath. Okay, in the adult, you label him as black. Okay. طيب. You assess, you open the airway, they will breathe. The start triad, there is no fifth. Yeah, no, if this is something else before that, if there is no. So this is the way how, if there is pulse, there's something else. Okay. Okay. Eye color. So he's crying. You assess the respiratory rate for pediatric 42. Kabir refill unable to obtain. Mental status, it's okay, fine. Wire it. Unable, huh? So you label him as what? Red. Okay, because they will do another triaging. You assume there is no pulse, or maybe delay. Okay, you get it? حاطه بالاحمر كمان. Right. So adult male using a chair for assistance. You will assist what? Respiratory 16, Kabir refill okay, mental status alert. تفضل. green, why? طيب. ليش يلو؟ يبغى له chair, huh? He's not walking alone عشان you green. So you label him as yellow. Clear? Yeah, mental status, it's okay, alert. You assist him, but you know he cannot walk and he's trying his leg. I need wheelchair, so this he can wait up to 2 hours, no problem. As the yellow. Okay? خلاص اعطيتكم الاجابه هنا ها خلاص هذا ريد اوكي this is a clear black okay so unconscious there is no visible injury RR is absent Kabir refill is absent and mental status and abscess so this is clear black okay is unconscious. He was just talking in the phone. So this is, you assess the respiratory rate is 18. It's okay, fine. Kabir refill is okay, but the mental status is disturbed. So you label him as red. Clear? So simple thing, you assess the mental status, respiratory, and Kabir refill. Here, the respiratory rate is 28, less than 30, and the Kabir refill is okay. Mental state is alert. So, green, okay? Do you have any question? ولا واضحة الأمور؟ 12 years old, male, ambulatory, non-visible injury, you assess the respiratory rate, 20. Capillary fill is okay, mental test unresponsive, so you label him as grade red. So conclusion, you should do the greatest good for greatest number for the patient, and then you will prioritize your patient according to your resources, and then avoid tunnel vision during triage. Thank you. يعطيك العافية. قاعد شكرا. الله يسلمك، ان شاء الله استفدت فيها. اقول ان شاء الله استفدت فيها. لا لا مشكلة. الله يسلمك.
الأبر جاي بليدنج. غير برضه هنا تخصص هنا دكاترة ونيرسة كلها، وقالوا لي والله اوكي. أول واحدة أمشي.
educated in the dermatologist and internist. He has an excellent track record of success in treating critical health issues, has experience in various healthcare conditions with various during and follow up patient care. Dr. Amjad Badawi will talk about the apparatus.
Thank you. طيب بسم الله الرحمن الرحيم. My name is Dr. Amjad Badawi. I'm newly joined gastroenterologist in An-Noor Hospital, and I have been asked to present these lectures about upper GI bleeding and make it as much digestible as they can. During the lectures, inshallah, we will cover this. It will be basic. I'm sure most of you are familiar with the information and content of this lecture. So we'll speak about the symptoms, the most common cause, and the workup and treatment. So why upper GI bleeding? I'm a little bit quite sure that everyone in this room maybe encounter or he will encounter a patient with upper GI bleeding, regardless of the specialty. So maybe you have been seeing the patient or definitely will see such patient. It's a quite common condition. This is from US population data. It's up to 80 to 100 person per 100 people each year. And it's carry a really huge mortality rate. Upper GI bleeding is a treatable condition, and in some extent also it can be preventable. So upper GI bleeding account for 75% of all gastrointestinal bleeding. So what's the symptom of gastrointestinal bleeding in general? So the commonest two symptoms of upper GI bleeding is melena or hematemesis. But sometimes maybe the patient can be asymptomatic with only anemia or low hemoglobin during the investigation. And also the symptoms of melena like shortness of breath, weakness, and so on. Historically, we define gastrointestinal bleeding that any bleeding from GI tract proximal to ligament of Therese. And this is usually give us the melena or coffee ground vomiting or occult blood in the stool and so on. But anything distal to ligament of Therese usually can label as the lower GI bleeding, and it can present as hematochezia or fresh blood per rectum and so on. Sometimes upper GI bleeding, especially if it is an arterial origin, can present directly with shock symptoms like hypotension, tachycardia, and the patient may be unresponsive, especially, as I said, in arterial bleeding. So what's the cause of upper GI bleeding? Peptic ulcer disease account for almost half of the case of upper GI bleeding. Also, esophageal disease like erosive esophagitis can be also the second in the list. Varicose bleeding also is a quite common cause of upper GI bleeding. Arteriovenous malformation also is quite common. But remember, anything in the any pathology in the GI tract can present with upper GI bleeding, from the benign things toward the malignancy. So anything. So peptic ulcer disease as you can see from the picture, peptic ulcer disease is discontinuation or defect in the integrity of the GI mucosa. So if you can see here, so the mucosa is really integrated, homogeneous. So any discontinuation or defect in the mucosa can be defined as peptic ulcer disease. Sometimes it can extend up to the muscularis layer. Usually, and it's commonly seen either in the duodenum, and peptic ulcer disease commonly in the gastric mucosa or in the duodenum. But also it can be seen anywhere in the GI tract. What's the commonest cause of peptic ulcer disease? So H. pylori and Anis aidei. This is really important during an Al-Hajj season to ask about Anis aidei. We have seen a lots of patients. I get surprised when I come here. I newly joined the hospital, so I find that the peptic ulcer or GI bleeding is really common. And most of the patients, they purchase Anis aidei over counter, and they come with really massive GI bleeding, and sometimes they come arrested. So ask about this medication. So that's why I put medications here and Anis aidei here to separate Anis aidei. So it's really common. And also H. pylori. Other medications, so like bisphosphonate and other things that can irritate the mucosa. As I said, remember, any pathology in GI tract can be manifested as an ulcer. So malignancy in the GI can be manifested as the ulcer. Infection also can be as an ulcer. Ischemia also can be manifested as an ulcer. So anything. That's why it's important to take pathology, or either to do a trial with BBI or eradicate H. pylori, and then call the patient for another look. But remember, ulcer is not necessary to be H. pylori. As I say, non-steroidal anti-inflammatory. It can be another thing also. So what is the diagnosis? Usually because the accessibility of AGD or gastroscope. So I think nowadays we use a list of another investigational modalities. So I would say AGD is the gold standard, and usually the first things that we do. We do very less barium and CT and such a study. So AGD in the diagnosis is usually is the first step after the laboratory, and this is the different morphology or classification of the ulcer. So we classify based on active bleeding. So either you see Forest 1 and Forest 2 usually indicate actively bleeding lesion, while Forest 3 is something that already controlled. The second most common cause of upper GI bleeding is GERD, or Hamoda gastroesophageal reflex. Yes. So the GERD is the condition that develops when the gastric content come to the esophagus. Some patients, unfortunately, prone to GERD other than the other, especially, for example, the pregnant woman, or those who has anatomical defect or congenital and connective tissue disease that can impair the motility of the esophagus. So all these can prone the patient to develop GERD. Also, some substances can precipitate or worsen GERD, like caffeine, smoking, alcohol abuse, and so on. So the key in the pathophysiology of GERD is the impaired of the lower esophageal sphincter, either because of the anatomical problem or by substance, as we mentioned here. Here, so as you can see, this is what we see in the in the GERD. This is the normal mucosa. So you see how defined mucosal anatomy or appearance of the normal esophagus. Here you can see there's like redness, irritation. This is minimally changed. Here is, we use usually Los Angeles classification, as you can see here. So the integrity is not impacted, but you can see here there's erythema and skin break or mucosal break. So this is class 1. Class 2 usually a little bit extended, or mucosal break is a little bit extended, but yeah, a little bit larger, but there is no connection between those two lesions or mucosal break. But here is a little bit more severe. There is a connection between the two mucosal break. But here you can see is like a full esophagitis, as we can call it. This is erosive esophagitis, and we see upper GI bleeding in this, but usually it's not a huge or massive GI bleeding, rather than either anemia or melena. But rarely to see hematemesis or frank bleeding in this esophagitis. Sometimes the patient complains of GERD symptoms, and in endoscopy has really clear mucosa. So it's worth it to do the pH monitoring. We just insert some sensor here in the lower, a little bit proximal to lower esophageal junction, and the patient get like a machine. So when he had the symptom, he just press on the machine. So we match his symptoms with the pH reading recording. Also, esophageal varices is the one of the commonest cause of upper GI bleeding. It's just like any varices in the body. Is engorged vein that can be ruptured anytime and cause really massive bleeding. We see it commonly in patients with cirrhosis, and usually they present with real massive bleeding. So this can be a fatal condition. But it can be seen in other conditions. So like, I think I have a slide with the classification of this. But remember, usually esophageal varices, it's seen when there is clinical significant portal hypertension. So anything that can cause portal hypertension can cause variceal hemorrhage. This is the pictures. You can see there's 3 or 4 grading. Number 1 is really minimal esophageal varices or minimal varices. Number 2, you can see here is different, but it's still, it looks like not full or maybe low risk. But definitely, if you can look at these 2 pictures, you know that this is like a bomb that can be ruptured anytime. And if it is ruptured, so it's miserable. And even for the treating physician, sometimes it's difficult to control. You just go in and you find this picture, or maybe worse than this picture. So you can imagine esophagus is really a narrow tube and full of blood. And yeah, so it's a fatal condition. So yeah, as I said, it can be seen in any condition that cause portal hypertension. And we defined it even since medical school for portal hypertension, either something that could happen prehepatic, like portal vein obstruction or thrombosis, if the patient has, for instance, pancreatitis or any inflammation, so he can develop portal vein obstruction, or post-hepatic, like patient with pericarditis, cholestatic pericarditis, or heart failure, or the commonest cause, intrahepatic, like in cirrhosis. I don't think that we need to look at this. Also, I might can skip this because maybe this is beyond the scope of lecture. This is how we diagnose, because sometimes it's difficult to diagnose portal hypertension, but I think we can skip this. So in general, you as a treating physician, either internist or gastroenterologist or ER doctor, so what is your workup for if you have a patient with suspected upper GI bleeding? So simple CBC, just to look for the level of hemoglobin, at least to have a baseline hemoglobin to be able to monitor the patient if he has rebleeding or something like that. Also the hematocrit, platelet, coagulation profile, chemistry, especially BUN and creatinine. BUN is very good indicator for upper GI bleeding. So raised BUN is strongly can indicate it, upper GI bleeding. Liver function test, this is really, really important, especially synthetic liver function tests like INR, albumin, and platelet. This can help to sort out if this variceal bleeding or is it just like another cause of upper GI bleeding. Also, as a primary physician who see the patient in triage, is good to have scoring system in your mind or when you communicate with the other doctor, internist or GI, so we can know is this patient need intervention or not, what's the mortality. So use this scoring system, Blatchford score, maybe Rockall score, need endoscopic variables, but at least Blatchford score. Why? Because if you told me the Blatchford score for this patient is 1 or 2, so we know that this patient maybe he doesn't need intervention, so he can be treated. It can be treated medically, but if you told me the patient has Blatchford score for 10 or maybe more, or 6 or maybe more, so we know that this patient most likely he will need intervention. It's really simple, just 4 or 5 variables. 2 of them are clinical and 3 of them are, or 2 of them laboratory and 3 of them, 2 of them, sorry, non-laboratory and 2 of them is laboratory. It's just BUN and pulse and symptoms. But it can't tell a lot. Maybe this can be skipped because this is need diagnostic also variable. Sometimes we enforce to do another radiological. Nowadays we do a little bit radiological modalities, but sometimes we enforce to request radiological investigation. The most common tree that we usually use rather than ultrasound or normal CT with IV contrast, just to look for pathology or the background of the GI bleeding, but sometimes we use CT angio, and this is very sensitive investigation. It can detect the lesion or intraluminal extravasation if the patient bleed at least 0.5 milliliter in the minute. So as you can see here in the arterial veins, so you can localize the bleeding site, but it needs to be done during the active bleeding. Sometimes we use the catheter angiography by our colleague in the interventional radiology. If we think that this patient maybe has a GI bleeding in area that cannot be reached by scope, for example, jejunum or if he has stenosis and we know that we cannot proceed with the endoscopy, so embolization will be a good choice. But also those 2 modalities need the patient to be actively bleed. So if he bleed and stop, so maybe this is not a good modality. Maybe you will not see anything. Also, radionucleotide imaging is a good and more sensitive than the CT or catheter angiography because it can detect the lower amount of GI bleeding as low as 0.1 milliliter per minute. So it can be detected. And also these radionuclide materials can be staying in the body for up to 1 or 2 days. And if the patient is bleed, so you can do a repeated imaging. If you failed in the first image, so you can detect maybe the bleeding in the second or third image. This is the catheter angiography, and this is how the intervention can be done. So the treatment, just like have this map in your mind, triage the patient if he come with upper GI bleeding rather with melena, hematemesis. So ask yourself, is this varicose hemorrhage or this is non-varicose hemorrhage? This is really meaningful for us and for the patient and for you. If he has any hint for liver disease or portal hypertension, for example, you find the patient has ascites, encephalopathy, or abnormal liver LFTs, or in the file he's labeled as a liver patient, so go to this pathway. Endoscopy, maybe the treatment is different between these two, but the most important is the medical treatment is also different. Here we use acid suppression agent, but here we use vasoconstrictive agent. And this treatment, medical treatment, is really show to decrease the mortality by significant percentage. So to sort the patient, if he is liver patient or if he has varicose or non-varicose hemorrhage, is really a crucial and critical start point. So before you call gastroenterologist or before you decide for the scope, remember this is a fatal condition. So the resuscitation is really important. This patient must have at least 2 IV access, large bore. Sometimes, unfortunately, we come to assist the patient who even has normal IV access. So remember, resuscitation might be important than even endoscopic intervention. So resuscitate the patient, replace the fluid, keep hematocrit in advisable level. And if you suspect non-varicose hemorrhage, start the patient on PPI directly. Better to give IV PPI. And then after this stabilization, so we can arrange laryngoscope. If you suspect varicose hemorrhage, so vasopressor is really helpful, and in most cases will control the bleeding or will stop the bleeding. Even it is not it's not permanent, but at least until the intervention can be done. So it's a bridging therapy. It's good. So telebrecine, it's used in Europe, but octreotide and other somatostatin analog like sandostatin is used in US and also in our hospital. And I think in most of the Kingdom hospital, they use this medication. So forget telebrecine because it does not persist. So usually we give the patient bolus 50 mg and then follow it by infusion rate of 25 to 50 per hours until the bleeding is stopped, and usually it will be stopped. So then we book the patient for urgent upper endoscopy. Previously, we give the PPI intravenous, and we continue the patient on intravenous PPI. But as you know, PPI intravenous is a bit expensive. So oral PPI is a good choice, and it shows a comparable result to the IV PPI. So at the beginning, yes, you might start with intravenous and keep him on drip until the endoscopy, because usually we want this patient fasting. But after intervention, so you don't need to follow the previous guideline to give him intravenous, just you can shift to the oral BBI. During the scope, we have multiple modalities to control the bleeding, either mechanical modalities or injection method, thermocoagulation, and hemostatic spray. If I come back here. For example, if we have patient with ulcer disease, like this, usually first 1 and 2. So this patient is actively bleeding, no way to just leave him without any intervention. This first 2 classification mean that patient is recently bleed and he most likely will re-bleed. So better to do intervention, and usually we do intervention. So maybe 2C and 3 is you can leave it alone. Just watch the hemoglobin and the clinical status. Usually we use 2 modalities. In our hospital, we use epinephrine and we close it by the clips, but also thermocoagulation can be used. It's also has a very good effect. So it's just a simple procedure. But if you give the patient IV BBI and we do the scope next day, usually we see the stabilized ulcer. So sometimes it's we don't need to interfere. So it's depends. It's depend on the lesion. Sometimes we inject, for example, if the patient has varicose, not varicose, if he has fundal or gastric varices, usually we cannot clip the vein. Usually we inject it with something that can induce some pulses inside the vein. If it is superficial arteriovenous malformation, usually we use ABC or argon laser coagulation. So each modality has its own indication, but remember that for the ulcer and for esophagus varices. This is treatment of actively bleed esophagus varices. As I said, resuscitation is the first step, but remember, over transfusion increase the risk for portal hypertension and rebleeding. In this group of patients, usually they do have high INR, also low thrombocyte. So try your best during resuscitation to correct the coagulation as much as you can with fresh frozen plasma, but nowadays we use fresh frozen plasma a little bit rarely, since the prothrombin complex concentrate that Oxflix and the other is found. Monitor mental status and avoid the medication that can precipitate to hepatic encephalopathy, like sedation and BPI. So that's why it's a little bit important from the beginning to decide. So if you suspect variceal hemorrhage, don't give BPI, because BPI plus GI bleeding plus the infection, so it's a huge, it's too much for the patient. We can stop the bleeding, but next day we find him encephalopathy. As I said, start IV octreotide or vasopressor, 15 micrograms, bolus followed by 25 to 50 microgram per hour. If we have telebracine, but I don't think we have it, start with bolus 2 milligram and then give every few hours. Erythromycin, good to have it, at least for us. You clean the stomach so we can have a better appearance of the stomach. So for esophagus varices, we have standardized treatment. If the patient is actively bleeding, we prefer to do band ligation than the whole injection. It's simple procedure. We just go to this varices steam, and we induce thrombosis by closure of the proximal parts, and you will see the steam, the entire steam will be collapsed. If we failed, sometimes we failed, the patient is actively bleeding, we have bad appearance, or sometimes he bleed here and here and here. So it's difficult to control. So just we insert this tamponade or the stent, self-expandable stent. But this is temporary, because if you failed in the first, for first modality, you cannot keep this. This is just as a bridging therapy till you see what the next is, a transplant, or you can place tips for the patient. If the patient bleed one time, so that's mean he will bleed another time. So how to prevent the recurrence of bleeding? Usually the rebleeding rate is in the first few days. So that's why we keep him on the vasoconstrictor for at least 3 days after active bleeding. Sometimes we call the patient after a few weeks for another session to see if there is remnant of esophagus varices. If we find varices and we think that the endoscopic treatment is not as effective for this patient, usually either we refer the patient for transplant, or we apply tips or send him for tips, which can decrease the portal pressure significantly, and it's really effective. What if the patient has varices but is not bleeding? So usually we don't interfere. We just give the patient non-selective beta blocker. This is a very good medication. It can reduce the portal hypertension significantly. But sometimes if the patient is contraindicated or he is not tolerated beta blocker, he developed, for example, dizziness or bradycardia. So still second line is an option. Like we just close the varices as we do with the active bleeding, either with band ligation or tips or whatever. Surgery nowadays become really rare in the management of upper GI bleeding, but sometimes yes, we need. If the patient or tips is not doable, sometimes the interventionist can also do like create shunt just to relieve the portal vein. So this is can summarize the upper GI bleeding. So if you suspect upper GI bleeding, first resuscitate the patient, stabilize the patient, and then ask yourself, is this variceal hemorrhage or non-variceal hemorrhage? If it is variceal hemorrhage, as we say, resuscitate, start vasoconstrictor, whatever available in your hospital, and also give antibiotic, because it showed that antibiotic can decrease the mortality. Most of the patient bleed. There is something that triggers the bleeding. Most of the time, it's the infection. So give the patient antibiotic, perform urgent endoscopy. I mean urgent, not urgent, urgent within 6 hours. If you're satisfied with intervention, just follow up the patient clinically and laboratory. If the patient rebleed, so sometimes we do another trial, but if you fail, so consider another technique like tips, or send the patient for transplant or shunt surgery. If you suspect non-variceal hemorrhage, So start directly BPI according to protocol, 80 milligram IV, and then 8 milligram per hour. Perform urgent endoscopy. If it is peptic ulcer disease, so depend on the what classification, is it first one or two? First one and two need intervention, while three maybe can be treated successfully with medical treatment. If bleeding stops, thanks, that's just follow the patient. If the patient rebleeds, you can do second attempt, or you can send him for the surgery if you know that, no, this is difficult, maybe this is the lesion or whatever, or lesion that is difficult to be controlled with the endoscopy, so you can send the patient for urgent surgery. But you can give him another chance or third chance sometimes before you decide surgery. Again, if you find, for example, another lesion, so treat the underlying cause. If it is arteriovenous malformation, as they say, sometimes we inject epinephrine and that's it. Sometimes thermal coagulation, it's work well with this patient. If you do EGD and suspect upper GI bleeding, but you find nothing, so consider to examine the entire GI tract. And I think this is beyond the lecture of today. Okay, that's it. Thank you. Any questions? No questions, huh?
than 15 years or older than 65 years. Large muscle mass, male sex, obesity, pre-existing dehydration, all these is considered risk factor for developing heat-related illnesses. Medical condition is an important part also. Patient with cardiac disease, patient with congenital disorder, diabetic patient, previous heat injury, recent or acute illnesses, sickle cell trait, and skin abnormalities. Of course, drug had also considered as a risk factor, especially patient on beta blocker, antihistamine, antidepressant, anticholinergic. So there's a lot of medications can exacerbate or exaggerate the heat illnesses. Here we can see that expected temperature in Mecca during Hajj from 1430 to 1450. In our year, in 1444, we can see that expected temperature can reach up to 50 degrees. And with the exertion, with the Hajj mission, these will lead to exposure to the heat and lead to the main risk factor of developing heat-related illnesses, as we mentioned. Here, some severity form of heat-related illnesses. Some considered mild one, some considered a moderate one, and of course, we had the severe form of heat stroke. In mild heat illnesses, we had heat edema, which is extremity swelling, occasional facial flushing, and this can be treated by moving to cooler area, elevate lower extremities, and diuretics not indicated, of course, because only to shift the one with heat edema to more cooler area, this will do the job. And of course, this is due to cutaneous vasodilation and vascular leak resulting in increased interstitial fluid. Another mild form of heat-related illnesses is exercise-associated muscle cramps. So what is the exercise-associated muscle cramps? As it's mentioned, it's muscle spasm, moist and cool skin with normal body temperature. Even in this case, just we have to move from the heat and to cooler area and rest and leg elevation. Stretching and massage, oral electrolyte fluid repletion also can be beneficial. The third mild form of heat-related illnesses is heat rash, malaria rubora, and it's eruption of red papules or pustules, primarily on neck, upper extremities, trunk, and groin. And how we can treat this one? Only by remove the clothes, evaporative cooling, and avoid topical emollient. Only to remove the exposure area from the clothes and evaporative cooling, this will treat the form of heat rash. When we move to moderate form of heat illnesses, we had the exercise-associated collapse, heat syncope, or of course, in our situation, due to exertion and movement in Hajj duty, so Hajj performance. So heat syncope, it's considered as lightheadedness, orthostasis, dizziness, transient loss of consciousness immediately followed cessation of activities. So how we can treat this one? Only by rest, in supine position, elevate legs, oral or intravenous rehydration, and prolonged recovery or significant cardiac risk factor should prompt further evaluation. So only if a patient had risk factor or chronic disease, as we mentioned, sometimes he needs further evaluation and observation to assure he's in good condition and he recover from the heat sample. The another form of moderate heat illnesses is heat exhaustion. And it's present sometimes by thirst, headache, fatigue, tachycardia, weakness, ataxia, syncope, nausea, vomiting, or even diarrhea, cold and clammy skin, and the core temperature ranging from 38 to 40 degrees. And this one should be treated by, of course, moving the patient from the heat to cooler area, rest in supine position, leg elevation, evaporative cooling, intravenous or oral rehydration sometimes needed. Delayed response require further evaluation. And the most severe form of heat-related illnesses is the heat stroke, which associated with altered mental status and seizure, and sometimes coma, tachycardia, hypotension, hyperventilation, diaphoresis, and the temperature, core temperature may will be more than 40 degree. And of course, to manage this one, you have to move from the heat area, manage airway, breathing, and circulation, and cold ice water immersion, sometimes needed in exertional one, not in the environmental one. Intravenous rehydration, hospital admission, of course, for the severe form. How we can diagnose heat-related illnesses? In history, as we mentioned, the most important point in history that patient had exposed to passive severe environmental heat. This is one classic heat stroke, especially as we mentioned in high risky patient, older patient, or patient with chronic disease during a heat wave, as in nowadays. Another form is exertional one, and is associated with severe or strenuous physical exercise. This can be present in younger adults, but the most important point here in Hajj is the classic heat stroke, which is related to environmental part. Central nervous system dysfunction. So patient with heat stroke present with central nervous system dysfunction, and is particularly an altered level of consciousness, which may range from confusion to coma. Some patient may present with agitation, lethargy, seizure, and ataxia, irritability. Hyperthermia above 40 degrees, measured rectally in all patients with suspected heat stroke. In practice, consider using an esophageal probe in intubated patients. So if patient needs intubation, we can use esophageal probe. Elevated core body temperature above 40 is consistent with heat stroke in the context of exposure to severe environmental heat or strenuous physical exercise. Anhydrosis is another noticeable symptom, that presence of hot, dry skin together with central nervous system dysfunction helps distinguish heat stroke from heat exhaustion. Whenever patient present with anhydrosis, we have to consider heat stroke more rather than heat exhaustion, which mainly present with sweating and wet skin, not anhydrosis and dry skin. So the presence of CNS dysfunction together with anhydrosis helps distinguish heat stroke from heat exhaustion. In patients with heat exhaustion, mental status remain intact. So the most important point to differentiate between heat exhaustion and heat stroke is the presence of CNS dysfunction, any symptoms of involving central nervous system, agitation, confusion, loss of consciousness. This lead to put us in that it's mainly a heat stroke case, not a heat exhaustion. And of course, the other one is as we mentioned, is anhydrosis and dry skin. This mainly related to heat stroke rather than heat exhaustion. So, and be aware that patients who present with normal temperature can have heat stroke. So sometimes patient had some cooling action in his tent, in his centers, other center before moving to hospital, and had some cooling measure. So be aware that sometimes patients present with normal temperature and have heat stroke, either because of inaccurate measurement technique or prior cooling in the community. As we mentioned, he get some cooling intervention before reaching these healthcare facilities. You should continue monitor the patient temperature while cooling and move to the management part. So clinical criteria to diagnose heat stroke is the most important point is the central nervous system alteration, as we mentioned, and elevated core temperature above 40 degrees. While in heat exhaustion, elevated core temperature 37 to 40 degrees, with sometimes mild CNS symptoms like intense thirst, weakness, anxiety, dizziness, but intact mental status, as we mentioned. And these symptoms can resolve within 2 to 3 hours. Here is some common symptoms can present for both heat stroke and heat exhaustion, like thirst, weakness, anxiety, dizziness, syncope, headache, nausea and vomiting also, sinus tachycardia, tachypnea, even jaundice, muscle tenderness, hypotension, and bruising and skin bleeding. All these common symptoms can present for heat stroke or heat exhaustion, but when we are seeing that patient is tachycardiac or tachypneic or had jaundice or muscle tenderness or with low blood pressure or some signs of bleeding, we have to consider more that patient is in heat stroke rather in heat exhaustion. So this is an important also point to differentiate between heat stroke and heat exhaustion. If patient, the most investigation to order for any heat-related illness is that we have to depend on rectal temperature. And of course, important investigation also full blood count to assess neutrophilia, anemia, thrombocytopenia, liver function test also an important part, because to rule out any end organ damage, even renal dysfunction tests you have to order, glucose level, electrolyte, ABG, blood gases, to rule out metabolic acidosis or respiratory alkalosis. creatine kinase, clotting profile, so and even urine analysis ECG. This is an important investigation to order when patient present to ER or in the heat stroke unit. This is an hospital intervention, not including the centers or OBD in the healthcare facilities. So whenever you suspect such a case of heat stroke, it should be referred to hospital. Even if the patient present to clinic, you have to shift it to ER or heat stroke unit to fulfill these all investigation and rule out any end organ damage. There is another differential for patient presenting like heat exhaustion or heat stroke. Delirium, one of them, meningitis, even one of them, and this can be excluded by lumbar puncture. DKA in patient with diabetes also can present with the same picture, but this one can also rule out by assessing the blood glucose and ketones in the urine. Hyperthyroidism storm also can be excluded by assessing the thyroid stimulating hormone, malignant hyperthermia also, neuroleptic malignant syndrome, serotonin syndrome is associated with patient. This one is clinical, and drug toxicity also, sepsis. So septic screen is an important part in assessing the patient presenting with heat stroke. When we move to the management part for the heat stroke or heat exhaustion, whenever we are in other facilities other than hospital, so pre-hospital management is an important part. The most important part is to remove from the hot place, assist and resuscitate, secure ABC, fluid and salt replacement, and of course, as we mentioned, measuring the rectal temperature. Rapid cooling as an important part. Should be done on hairless area by ice packs, wet towel, even sometimes chemical packs if available, fans until temperature below 39 degrees. This is an important point that whenever we reach the temperature below 39 degrees, rapid cooling should be stopped to prevent hypothermia. So whenever we reach the temperature below 39, any active cooling should be stopped. And of course, as we mentioned, transportation to ER or heat stroke units in the hospital and maintain safety. So this is an important pre-hospital management. What about if the patient reaching the triage area in the hospital? The most important point is to assess the temperature rectally. Sometimes in practice, even in hospital in Al-Mashaa'ir, sometimes it's difficult to give the privacy for the patient to do rectal temperature. So we can deal with the regular temperature in triaging area. It's depends on the hospital pathway and hospital facilities. Some hospital had heat stroke unit alone. Some hospital is joined with the observation of the ER. So it's depends. Because of this, sometimes we can use the regular temperature to direct our patient even to heat stroke unit or to observation part of the ER in the hospital. And after that, we can, after stabilize the patient in heat stroke unit or in the observation of the ER, we can do rectal temperature. But if the heat stroke unit is in the same ER, so we can shift patient directly to ER and do rectal temperature in his bed. If the rectal temperature above 40 degrees plus history of exposure to severe environmental heat, and this course in Hajj will be known to all of us. So this should be to heat stroke resuscitation unit. If cooling measure initiated before patient reach to the ER or triaging area, but there is altered mental status or seizure, even for those patients, heat stroke resuscitation unit should be referred to. But if the rectal temperature below the 40 degree with normal mental status, this mainly going with the heat exhaustion, not the heat stroke, as we mentioned. So we can shift to cool or observation room in AR. If the patient came walking, and of course, if patient came walking, so he will come through clinic or OBD part of the hospital, as in Mashair hospital's regulation that anyone came on his foot walking ambulatory, so he will go through OBD clinic rather than ER. So if patient came walking and temperature below 38.5, this patient can be managed in OBD and assist. If we assist the patient and we had elevated temperature, so we can after that shift him to AR. Here another algorithm of the how to deal with the patient coming to ER. First, we have to assess the signs of heat stroke. Is it heat stroke or heat exhaustion? By follow the central nervous system dysfunction to assess for central nervous system dysfunction. If it is available, if it's a patient suffering from it, so we have to confer or suspect temperature above 40 degrees by rectal temperature. If no, patient temperature is below 40, so we have to consider an alternative diagnosis. But if yes, patient had central nervous system dysfunction plus temperature above 40 degrees, so we have to treat for heat stroke. But if patient does not have any central nervous system dysfunction signs or symptoms, so we can treat as heat exhaustion, not heat stroke. Heat exhaustion, the most important part in treating heat exhaustion is the in hospital, of course, that we should water and salt containing solution if the patient is not nauseating or vomiting or manifesting a depressed mental status. So rehydration is an important part in heat exhaustion treatment. If the patient is not tolerating, check blood pressure. If flow, establish an IV line, give IV bolus of normal saline, 15 ml, then maintain IVF normal saline at 125 ml per hour and titrate the response. You have to monitor vital signs, rectal temperature, and oxygen saturation, of course. Using ice packing to axilla and groin with fan is also an important point in managing patient with heat exhaustion. Avoid using the antibiotic for temperature control and exclude other causes of hyperthermia. How we can tell that patient is recovered from heat exhaustion? When he had normal vital signs, well hydrated, and no other symptoms or signs of illnesses. For heat stroke, the most important point is the ensure ABC, and sometimes patient may need mechanical ventilator. After that, resuscitative measure and evaporative cooling. This is an important point, to resuscitate the patient, circulation, and to cool the patient. This is the most important 2 points, to resuscitate and cooling. Of course, this investigation, we already mentioned the importance of each one of them to look for differential and complication of heat stroke. Stop cooling, as we mentioned, we have to stop cooling whenever rectal temperature reach 39. So this is an important point to prevent hypothermia. Our treatment goal in heat stroke, that also we had to go back to normal vital signs, EU hydration state, full consciousness, normal investigation, and no complication. The most two important management plan is to resuscitate and ensure that he had in good circulation by fluid and IV line, as we mentioned, and monitoring of the central venous pressure sometimes needed, especially in ventilated patient. Cardiac and hemodynamic monitoring, full catheter out input monitoring also, and of course monitor vital signs. And this the intensivist care, of course, to ensure we had good circulation. The other one is the cooling part. So for cooling part, whenever the temperature is still above 40 degrees, we had to do evaporative part and cooling measure by fan and by the water spray. And we have to continue in measuring core temperature by rectally. Measuring should be stopped once the rectal temperature is less than 39 degrees. And there is, of course, as we mentioned in heat exhaustion, there is no role of acetaminophen or aspirin in the management of heat stroke. For follow-up, we should monitor temperature regularly, and sometimes we have to also use esophageal probe in practical to be practical in intubated patient. Of course, as we mentioned, laboratory tests to differentiate the diagnosis and to look for complication and other organ involvement, as we mentioned. If the patient is critically unwell or there is evidence of organ failure, consider repeating blood more frequently to repeat the investigation. Be vigilant for complication that may develop at the later stage, even after return to normothermia, including rhabdomyolysis, acute kidney injury, disseminated intravascular coagulation, and acute liver failure. So we have to look and investigate for the later development complication. Of course, here is some complication associated with heat stroke, and even there is a long-term complication like cardiovascular disease. So there is some studies showed that after heat stroke, we had increased risk of myocardial infarction and cardiovascular disease. Prognosis, mortality from heat stroke in older adults can exceed 50% and is considered a very high mortality rate in elderly patients. In adults, depend on several factors. The prognosis depends on several factors, such as amount of time patients remain in elevated core temperature and the extent of hyperthermia. And all severe complications of heat stroke are increased in relation to this. Comorbidities for the patient is an important prognostic factor. If the patient had chronic diseases, this will worsen the prognosis for recover from heat stroke. Other poor prognostic indicators include prolonged coma or shock, presence of rhabdomyolysis, and more severe end-organ damage like elevated creatinine kinase more than 1,000, and the development of pulmonary complication, including acute respiratory distress syndrome. Patient with history of heat stroke may be more likely to have heat stroke again. So this is also an important point that patients had increased risk of heat stroke again. By this, my talk has ended, and I hope it was informative to all of you. Thank you so much.
Hello? Yes, we are going to start a talk about drug safety during mass gathering. First of all, we have to identify what is the mass gathering. Mass gathering is defined as a large number of people, more than 1,000 at a specific location during a specific time. Travelers to the mass gathering usually facing a unique risk because of several events associated with their first of all, increase the risk of hazardous environmental, challenging security situation, and increase the opportunity to catch any infection during the crowded and poor hygiene from the temporary food and the situation facilities. Saudi Arabia, Hajj and Umrah pilgrims. Infectious disease risk. As we said, that there is an increase of the risk that we can catch the infections easily during the crowded and the mass gathering. The Saudi Arabia can elect a restriction to the entry from some countries that have an outbreaks of certain disease like Ebola that happened during 2012. Saudi Arabia did not permit anyone from Uganda to attend the Hajj during the Ebola outbreak in that countries. And the same restrictions were applied to Ghana and Liberia and Sierra Leone in the 2014 and 2050. First, the consideration of vaccination. Vaccination is targeted to reduce the infection. There's 4 types of vaccines that is necessary for Hajj, for the pilgrims, and also the healthcare worker to take, like influenza vaccine, pneumococcal vaccine, poliomyelitis, and the yellow fever vaccine. First, we are going to start our talk about the yellow fever vaccine. In the yellow fever vaccine, there is a certificate that has to be shown by the vaccinated personnel that at least 10 days and not more than 10 years before the arrival to the Saudi border. In the case of absence of the certificate, the individual will be placed under strict condition for surveillance for 6 days from the date of vaccination or to the last date of potential exposure to the infection and whatever is area. Meningococcal vaccine. We are having several types of meningococcal vaccine. There's 2 types. Nowadays, we are having the new one that called MenB vaccine, and we are having the traditional one that is the polysaccharide, the quadrivalent polysaccharide vaccine. This is considered very necessary type of vaccination that have to be taken by even us as a healthcare provider and the pilgrims, not more than 3 years and not less than 10 days before the arrival to Saudi Arabia. The main difference between the quadrivalent polysaccharide and the MenB is the pediatric cluster. MenB can be given to the pediatric cluster younger than 2 years old, but the quadrivalent polysaccharide cannot be given for the ages under the 2 years old. Visitors from African countries, they are located in the meningitis belt. And countries that have an outbreak of meningitis, they have to state the requirement for the entrance by taking the meningococcal vaccine before entering the Saudi Arabia, but there is an additional things that they have to take to reduce their ability or the rate of being carrier, is to take ciprofloxacin tablet 500 milligrams as a chemoprophylaxis at the port of entry to lower their rate of being a carrier. Interior pilgrims and the Hajj co-workers, we have to be vaccinated even for the meningococcal vaccine. It is required for whom? All citizens and residents in Medina and Mecca who are not being vaccinated for the past 3 years. All citizens and residents undertaking the Hajj, all Hajj workers who have not been vaccinated in the past 3 years, or any individual working at the entry point or direct contact with the pilgrims in Saudi Arabia. Polymyelitis. The main things that we are focusing on the patient, on the pilgrims that or travelers that arrives from bio-endemic countries, which is namely Afghanistan, Chad, Nigeria, Pakistan. Regardless of the age and vaccination status, they should receive a 1 dose of oral polio vaccine at the entrance. And if it's border line, they have to take it. Proof of vaccination at least 6 weeks period to the departure is required for visitor from bio-endemic, and re-establishing the transmission countries to apply for entry visa to Saudi Arabia and receive 1 dose at the border point in the Saudi Arabia. Seasonal influenza. This is the first vaccination that have been taken by all of us as a healthcare provider and even Hajj co-workers. It is usually taken yearly, but we are focusing on the specific type of patients. The patient they are that's with immunocompromised patient, the patient with a chronic heart or lung disease, asthmatic patient, AIDS and HIV patients, pregnant women, children under 5 years old, because they are going to suffer from a severe type or severe cases of influenza if they got the infections. Now we are going to talk about the response to the international MERS-CoV precautions. Saudi Arabia Ministry of Health recommends that the elderly, that they are above 65 years of age, and these with the chronic heart disease, chronic kidney disease, respiratory disease, diabetes, and pilgrims with immunodeficiency disease, congenital or even acquired, malignancies, and pregnant women, children under 12 years who's coming to Al-Hajj and Umrah to postpone their performance of Al-Hajj for their own safety. The Saudi also advised all pilgrims to comply with the common public health guideline to curb the spread of respiratory infection, like what? So it can be summarized to washing hands with soap and water or disinfectant, especially after coughing and sneezing. Use disposable tissues with coughing and sneezing even. Try to wear the mask and avoid the contact of hand and eyes and nose, not to touch it. Avoid direct contact with infected persons. People with symptoms of cough, sneezing, vomiting, diarrhea, we have not to share their own personal gate rate. For the general precautions, we are having the updated immunization against some diseases, and there is 2 types of vaccination that we have to take care as an entrance. First, the specific needs for Hajj from travelers, like the one that I discussed, like a meningococcal vaccine, myelitis vaccine, yellow fever vaccine, and the others, which is what? The national immunization schedule. Likely that include that diphtheria, tetanus, measles, mumps. Emergency precautions in the event of public health emergency of international health concern, in these cases of disease outbreak subjected to notification under the international health regulation that established at 2005. We have to take the measures that be taken above by the vaccination, and even to depend on the spread of the type of the infections, like what happens in the COVID-19. We reduced the number of patients. In case of Ebola, we didn't accept any pilgrims that comes from the countries that have an outbreaks. They take every infection or every type of the outbreak to deal with it individually and according to their country and origin. Enteric infections and diseases that usually happens in the management or during Hajj. First, diarrheal disease. During the traveler diarrheal disease that usually occurs associated with taking of antibiotics and can be associated with infection of bacteria, virus, and even parasite. C. difficile are usually associated or occurs after treatment of bacterial infection, especially when the patient were treating with fluoroquinolones and vancomycin even. It's occur. And usually the C. difficile is usually associated after like an opportunistic infection after the antimicrobial treatment completion. The initial workup for persistent traveler diarrhea is always include a C. difficile stool toxin assay. And we usually prescribe for this type vancomycin, fidaxomicin, or less opportunity to because it is less optimally to metronidazole to cover that. In the case of mild diarrhea, antibiotic treatment is not recommended. Consider treatment with bismuth and subsalicylate or loperamide. For moderate type, antibiotic can be used for the treatment like azithromycin, fluoroquinolones, rifamycin for antimotility drugs, and consider sometimes loperamide for the use as monotherapy or even as adjunctive therapy. In the case of severe diarrhea, antibiotic treatment is advised even as a single regimen may be used. Then if we can't give ciprofloxacin like a dose by 1,000 for 1 day. Azithromycin is preferred, fluoroquinolones, antimotility drug, and loperamide as adjunctive, and not recommended for monotherapy for patients with bloody diarrhea. The treatment option usually falls as azithromycin 1,000 as a single or divided dose, or we can give 500 milligram OD for 3 days, ciprofloxacin 750 milligram as a single dose even. We can use instead 500 milligram PID for 3 days, levofloxacin, ofloxacin, rifamycin, and rifamycin. All of them are the treatment option or the treatment antibiotic option that can be used for that type of diarrhea. Skin infections. Usually for protection, we are advising patients to keep their skin dry using talc powder and to be aware about any pain or irritation that caused by garments. The traveler, usually, especially the patient that they are suffering from diabetes or diagnosed with diabetes, we are asking that patient to cover their feet with appropriate coverage to avoid wounds and sores, and we are advising them to cover their legs properly because the Grand Mosque and they cannot just wear their shoes. Climate and sun exposure. For that reason, the Hajjis maybe walk up to 35 to 40 miles over 5 days About 45% of these pilgrims work during these rituals. They counsel the pilgrims to stay hydrated, wear sunscreen, and seek shade for and use for umbrella when it is possible. The sunscreen that they have to use not less than 30% of the UV protection. Consideration about choosing a drug for malaria prophylaxis. When you are choosing a drug for malaria prophylaxis, we are depending on the three medications mainly: mefloquine, primaquine, and deoxycycline. And our decision to choose which one is depending on the type of your patient. When you are assessing your patient, of course, you're not going to give deoxycycline for a pregnant lady because it is prohibited. And if it's not acquired, it is not fit to give it to a pediatric patient. And you have to assess the patient individually. The recommendation for drugs to prevent malaria is different from country to travel that traveler originated from, and the information in that countries even. It is not associated with their No anti-malaria drug is 100% protective and must be combined with the use of protective measures like insect repellent, long sleeves, long pants, sleeping in a mosquito-free setting, and use of insecticide treated at night. For medicine, also consider the possibility of drug-drug interaction with other medications that the person may be taking, like for chronic disease and allergies. When several different drugs are recommended for this area, as what I said, the mefloquine, primaquine, and the deoxycycline. Menstruation. As the Muslim law prohibits person who have menstruation from performing a tawaf, women have to seek for menstruation to manipulate their menstruation cycle, should be consult a physician before the ceremony of Hajj by 2 and 3 months before the journey. And this falls in the two medications that have to be used, that the tranexamic acid and the Formulotin to delay the menstruation. I hope you enjoyed what you listened. Thank you for giving me your time.
welcome everyone again. And our talk will cover the all common clinical condition during Hajj, as we all know that regarding the Ministry of Health regulation in Mashair hospitals and health centers, that any patient walking and came to health facilities ambulatory, he should go through even OPD clinics in the hospitals or in the health centers all over the Mashair area. And ER visit is only for the ambulance and Red Crescent facilities. So we'll go through the most important clinical condition that we will face in the ambulatory care rather than ER care. In the studies done in 2015 for the assessing the disease pattern among patients attending the centers during Hajj, we can see that the most of the patient visiting clinics in Hajj period is suffering from respiratory problems, following by skin and gastrointestinal disease. And less than 25% of patients were referred to the hospitals. What is the most common presentation to the pilgrims to the ambulatory care in and healthcare centers and OPD clinic? As we can see in this study, that respiratory problem is the most common presentation, and it's reflecting 17% of all visit to the ambulatory care services, followed by skin diseases, which is 15%, and gastrointestinal disease, rheumatology, cardiovascular disease, orthopedic, endocrine, urology, followed by ENT issue, followed by neurology, gynecology, surgery, psychiatry, and headache complaint and fever complaint. In the literature review done in 2019 regarding the health issue in Hajj for pilgrims, it's classified into three main categories: even communicable disease or non-communicable disease, and of course health services provided. For the communicable disease, meningococcal disease is an important part of the communicable disease, and of course, as we mentioned, respiratory tract infection, diarrheal disease, and emerging new infectious disease, as we are facing now the prevention and of course to take care for the new emerging infectious disease like Ebola in nowadays. For non-communicable disease, the most important part is the pre-existing chronic illness and trauma, and followed by surgical issue, followed by, as we talking previously, heat injury. So we'll go through some important management plan for the most common presentation to the ambulatory care services in Al-Hajj, like respiratory, ENT, skin diseases, gastro, uro, cardiovascular, endocrine, neurology, musculoskeletal. Of course, a lot of topics already mentioned in this symposium, in yesterday talks and even in the today talks. So we will go through it fast and to cover only the most important point in each complaint. If we start with the respiratory part, the most common presentation to ambulatory care is respiratory tract infection, and can reach up to 60% of visitors to the healthcare clinics of the pilgrims is due to respiratory tract infection. When we are calling respiratory tract infection like pharyngitis, viral upper respiratory tract infection, tonsillitis, these are the most three health issue and represent 85% of the total diagnosis. Pneumonia, of course, we have to consider it as an important health issue that sometimes need admission, sometimes need further investigation. And of course, it can be presented through the clinic and through ambulatory care. So all the staff and physician in the clinical ambulatory care clinics should be aware when he should refer the patient to ER department to prevent complications. So if you can see that about 69% of patients receive symptomatic treatment and oral antibiotics. So most of the patient can be treated in ambulatory care clinic, but sometimes may need admission and even life-threatening condition and need ICU admission. So the most important part for all our physician and staff in ambulatory care clinic is that he can fastly scoring the patient according to CRB 65. If the patient has any signs of confusion, so this is 1 point. Any patient had respiratory rate above or equal to 30 breaths per minute, this is 1 point. If the blood pressure is below 90 systolic or below 60, this is 1 point. If the patient is above or equal to 65 years old, this is 1 point. If the patient score any point, it should be managed in ER or in admission department. If the patient scores 0, no red flags for the patient, we can start first line therapy with oral antibiotic and of course supportive care regarding the presentation of the symptoms. And of course, chest X-ray can confirm the diagnosis for the community acquired pneumonia. Any patient had even 1 point scoring, he should be evaluated in emergency department and maybe need to be admitted to the inpatient care for IV antibiotics and further evaluation and management. TB can be presented even in the ambulatory care. So the most important is that it's 3 times higher in Mecca than the national average in Saudi Arabia, and TB infection rate was 10% among Hajj pilgrims, which is higher in reported incidence than general travelers. Viral respiratory tract infection, like most important one is an influenza, and nowadays, alhamdulillah, we had the benefit of influenza vaccine, and as we can see that with influenza vaccine, 77% decrease in the admission due to influenza. Pertussis infection also can be present, but and had incidence rate of 1% among pilgrims in previous studies. For influenza, the most important management plan that we have to start antibiotic analgesic, and we can consider antiviral therapy, oseltamivir 75 milligram oral twice daily, And antibiotic also, we can consider initiating antibiotic if we suspecting bacterial superinfection with cefuroxime or any antibiotic available. For asthma exacerbation, the most important point that if the patient present to ambulatory care clinic and he speaks normally, respiratory rate is below 25 breaths per minute, pulse rate below 110 beats per minute, he can be managed in nebulizer room by starting the supplemental oxygen and salbutamol inhalation, 5 milligram inhaled via nebulizer every 20 to 30 minutes. And we can consider even ipratropium inhalation, even prednisolone, corticosteroid can be given 40 to 50 milligram orally once daily. But this an important point. Whenever patient present to a clinic with subjective report of severe difficulty breathing, or it's can see he is using accessory muscles and to breathe, or he has a history of failure to respond fully and promptly to treatment. If you treat the patient in with the good nebulization and frequent nebulization and no improvement, so or history, previous history of severe asthma attack or history of ICU admission due to asthma, even if patient present even with associated fever, so this patient should be referred directly to ER. For another presentation is acute bronchitis, and it has a criteria of McFarlane that patient with acute bronchitis had history of cough less than 21 days and at least other lower respiratory tract infection like sputum production or wheezing or chest pain with cough. So whenever patient has history of predominant cough with another lower respiratory tract symptoms, so we can consider that patient is suffering from acute bronchitis, and only we have to give him antibiotic. Short-acting bronchodilator is also an effective management. Antitussive like dextromethorphan 20 milligram orally every 4 hours when required also can be effective. Whenever patient present and with severe dyspnea or severe chest pain or rigor or hemoptysis, patient should be further evaluated in ER and may need admission. For the ENT common issue presented to as ambulatory in Al-Mashaa'ir or in any healthcare facilities, we had the common one is the presentation with acute sinusitis. So patient came with symptoms less than 10 days. This may consider mainly viral one. If the patient give history of symptoms more than 10 days, this is mainly bacterial one. So this is important to differentiate between viral and bacterial acute sinusitis in quickly managing a patient present to ambulatory clinic. Symptoms that worsen after an initiative improvement, this also can consider as bacterial sinusitis. For the management of the viral one, antibiotic, analgesic, decongestant can be used, pseudoephedrine can be used, intranasal corticosteroid also can be used, and intranasal saline washing is an effective way to manage patient presenting with less than 10 days of sinusitis. If if it's more than 10 days and you suspect bacterial one, so you have to start to give him antibiotic therapy like amoxicillin, clavionate, augmentin, and you can consider doxycycline and clarithromycin for managing bacterial one. Another common presentation to ambulatory care clinic is acute otitis media with symptoms of otalgia, preceding by upper respiratory symptoms, bulging tympanic membrane, irritability, sleep disturbance, and fever. So the most effective treatment is antibiotic initiation with amoxicillin, clavionate, and you can consider cefuroxime and ceftriaxone if indicated. Otitis externa is also a common presentation during Al-Hajj. So it's mainly bacterial one. So pain management is a point, and antibacterial otic drops like ciprofloxacin, dexamethasone otic drops, and ofloxacin otic drops can be given to manage the acute otitis externa. If you suspect fungal one, so topical or treatment with acetic acid otic drops is also can be considered for treatment of fungal one if you suspecting in immunocompromised state. What about skin diseases that's common to be presented in between the Hajj? Skin infection. One study included 1,441 patients at an outpatient dermatology clinic in Mecca during 2 Hajj season. Primary bioderma, including impetigo, carbuncle, furuncle, and folliculitis were the commonly seen. And even secondary bioderma like the complicated eczema can be seen. Other conditions including cutaneous leishmania in 2 patients is nowadays, alhamdulillah, it's not that much common. Dermatitis of various etiology and even high incidence of skin diseases such as bioderma and intertrigo among pilgrims. And I think most important skin presentation to ambulatory care clinic is intertrigo. When we are seeing this picture, we can see that it's dermatophyte infection, like this one, tinea facial, which can common presentation in the beard area or mustache area. Another one is tinea corporis involving the body with a scaly lesion with intact center of the lesion. Tinea cruris mainly presenting between in groin area and thigh area. And tinea pedis, of course, this is most common one, especially among patients with chronic disease involving the lower extremities. So whenever you notice any tinea infection, so you can start patient on topical antifungal therapy, terbinafine topical 1% for children, and you have to apply it 1 to 3 twice daily for 1 to 3 weeks. Also, you can consider topical aluminum acetate for the management of tinea infection. Eczema is also a common presentation during Hajj time, especially if it's chronic. All we know it's chronic disease with acute flare symptoms. So whenever patient present with the acute flare of the eczema, you can give him emollient treatment, and you can consider intermittent topical corticosteroid to manage the acute flare. Hydrocortisone topical apply to the affected area twice a day. Another one, it's common during Hajj and between Hajj is the intertrigo from the movement and it can be presenting with pruritus, burning sensation, tingling, and pain in the skin fold and flexural surface. If there is an acute change in the quality of the symptoms, consider a secondary infection with Candida. So it's presenting mainly in the skin fold and flexural surfaces due to contact and movement, especially in the hot weather. So it can be seen in any skin fold or flexural surfaces. So how we can manage this? By triple paste compromised of containing aluminum acetate solution, zinc oxide, and of course petroleum, is like Vaseline, is an effective antiperspirant that also reduce frictional exposure. The main issue with this intertrago is friction exposure and due to movement and skin irritation. Topical nystatin can be considered if you suspect super infection with fungal infection. Even oral one can be considered if had a severe form. Impetigo also is presenting commonly and can be treated with topical antibiotics. Bears is also a common presentation during Al-Hajj due to hot weather and sometimes patient presenting with different degree of burn. So if the patient had primary degree, so you can clean the wound and give him topical antibiotic prophylaxis like silver sulfadiazine topical 1%, and to be applied twice daily. You can consider give him tetanus immunization if it's available or it can be practical. Analgesic also sometimes needs because of the pain, but be aware that any patient who cannot take fluid by mouth or need burn resuscitation potentially have inhalation injury if you suspect had like that. So and you have to refer him to ER for further management and fluid resuscitation. ORF is another condition among patior that walker during Al-Hajj. This blister came from the Udhiyah and contacting with the sheep, and can be this blister should be cleared around 6 weeks and not contagious. What about gastroenterology common presentation as ambulatory clinic? Diarrheal disease, I will not go in thoroughly because it's already had talk about it. So the most important point here that sometimes patients present with only truffle diarrhea with no red flag. Yeah, patient present only with mild form of diarrhea and he is vitally stable. So you can start him on loperamide 4 milligram orally initially, then 2 milligram after each stool, up to 16 milligram per day. Bismuth also can be used. Antibiotics like azithromycin and ciprofloxacin single dose can be effective management of traveler diarrhea. Red flag for this, you have to assure that patient does not have bloody stool, does not have any history of weight loss, not passing urine. So if any of these or patient look dehydrated, so refer him to ER. Of course, this one last epidemic of cholera was 19 89, and alhamdulillah, after that, no report of the such an issue. Hepatitis A also common presentation, and it's common during Hajj, but there is no data available for that. Food poisoning already mentioned in separate lecture, and it's common to be presenting in clinic. So the most important point that if patient is stable and no signs of dehydration, you can start with the oral hydration, anti-peristaltic agent, and anti-diarrheal agent. If severe form or the dehydration signs or symptoms, so refer him to AR. Some presentation to clinic, it's acute abdomen. So preferably any patient present with acute abdomen, better to be evaluated in emergency care. So patient presenting with acute abdomen, better to be referred to emergency care to further evaluation, as sometimes it's related to appendicitis, pancreatitis, kidney stones, duodenal ulcer disease, cholecystitis. So better to be further evaluated in any patient present with acute abdomen to be referred directly to ER. For urogenital presentation in Al-Hajj, urinary tract infection is the most common one. And to start antibiotic, any lady present to the clinic with two or three of the key diagnostic signs and symptoms, which is dysuria or new nocturia or cloudy looking urine. If patient had two of these three or three of these three, you can start empiric antibiotic. If present with one only and had you have available lipstick, so you can also start empirical antibiotic therapy like nitrofurantoin can be started for 3-day course with 100 milligram orally. For urinary tract infection, be aware that the key symptoms of UTI in women over 65 years and new onset of dysuria, plus two of the other symptoms. So better to be further evaluated in ER. So any patient elder with high temperature or incontinence or CNS complaint, suprapubic pain. So you have to consider another diagnosis or pyelonephritis to be ruled out. So better to be referred to ER for further evaluation. For vaginitis, if patient present with vaginal discharge, dysuria, so it's bacterial, mainly it's bacterial vaginosis, and you can start on metronidazole 500 milligram orally twice daily for 7 days, or if it's available vaginal gel, you can or cream, you can use it. But be aware that if patient tried this treatment before with no benefit, or had pelvic pain, or had fever, nausea and vomiting, to be further evaluated. Urethritis also can be presented among Hajji, and this should be treated with ceftriaxone injection plus gentamicin or azithromycin. Epididymitis also can be presented with unilateral scrotal pain and swelling of gradual onset and symptoms mainly less than 6 weeks. So you can also should be treated with ceftriaxone 5 milligram intramuscular as a single dose, like the previous one. Doxycycline also can be used. For cardiovascular disease, all we are know that the cardiovascular disease is the most common cause of death among Hajj, and it's reaching to up to 43% of deaths among Hajjis is due to cardiovascular disease. And of course, hypertension is the important subject, and it can be seen a lot among patients presenting to ambulatory clinic. Just you have to be aware that if patient had look like he's clinically unstable or vitally unstable with blood pressure exceeding 180 for systolic or 120 for the diastolic, patient should be evaluated in ER, not in the ambulatory care services. So patient with hypertensive emergency should be admitted to the intensive care for continuous monitoring of blood pressure and target organ damage, and for parenteral administration of appropriate therapeutic agent. Any readings below this with vitally stable patient can be rested for and to be observed for a time till his blood pressure within the normal range, especially if he had history of missing his medication. So you can prescribe to him his own medication and to observe him in observation room till he had a normal blood pressure reading. If patient present with less than this reading, if patient had above of this reading, better to be evaluated in ER to look for any signs or any end organ damage results, and it should be had chest X-ray and ECG and all blood work. For heart failure, many patients can present to clinic with history of heart failure, but whenever the patient presents to your clinic with exacerbation, acute complaint, better to be evaluated in ER, but you can give him oxygen if it's difficult to, if you are in a far ambulatory care clinic, so you can start him with oxygen till reaching the hospital. MI also an important subject, and some patient, especially with chronic disease, can be present to you in the clinic rather than ER. So you should be aware of any chest pain complaint or dyspnea, and should be assist in a good an important pattern that is maybe MI. So to be referred, better to be assist in ER rather than the clinic. And of course, all we are know that the time pattern in managing myocardial ischemia is an important part in the management. So try to shift him as soon as possible to ER if you are in the same hospital in the OPD, or by ambulance if you are in the far away clinic facilities. Sepsis also an important point and presenting in the clinic. For endocrine, for DKA also it has a separate talk yesterday, so I will only be that any patient present with high blood glucose reading, especially if he is type 1 diabetes, better to be evaluated in ER. But if the patient is type 2 elderly patient with the history of type 2 diabetes, and he is missing his insulin dose, or he's missing his medication, so you can give him his missing insulin dose or his missing medication and observe him till he had good control of his blood glucose. But whenever you had high readings, even if he is type 2 and his blood glucose more than 250, better to be further evaluated for DKA or hyperosmolar condition, especially with exertion of the Hajj. So better to be shifted to ER. And of course, if you are far away from the hospital in the other ambulatory clinic, so you can start him on normal saline for rehydration. The most important is rehydration, and to give him his insulin injection, but never to start him on IV insulin, because it's risky if you don't have lab work. So better to be evaluated in ER facilities. For hypoglycemia, you can give him oral glucose if available, or to give him any source of carb, and monitor every 15 minutes till the blood glucose level came back to normal one. For neurology, ischemic stroke, also we had the separate talk for that, and I will pass it. For headache and vertigo and dizziness. For headache, the most important red flag that the patient should be further evaluated in ER, and no place for antibiotic or analgesic or painkiller. If the patient had sudden onset of new onset headache, or if the headache is either sudden onset or progressive, or associated with focal neurologic signs, or any other cerebrospinal sinus CNS symptoms. For vertigo or dizziness, if presented with diplopia or dysarthria or weakness, it should be this considered a red flag. If there is ptosis, considered red flag. Is absent gag reflex, also considered red flag. If had chest pain or palpitation, is considered red flag. Meningococcal disease also can be presented, and single dose of 500 milligram of Cipro to all pilgrims before arrival is considered one of the preventive measure for that. And of course, if it's an hospital management, not ambulatory care, but we can consider that this preventive measure for a single use of 500 milligrams ciprofloxacin. For ophthalmology, common ophthalmology presentation, acute red eye or vision loss. Some patients can present with viral conjunctivitis or bacterial one or allergic one. The main point here that if patient had severe eye pain or blurred vision or headache with photophobia or excessive discharge, this patient should be further evaluated, not to be managed in ambulatory care services. Acute angle closure glaucoma is an important diagnosis and should be treating as soon as is diagnosed. So it's if patient present to the clinic with pain in the eye plus blurred vision plus halos around the light seen from the one eye, this patient should be managed in hospital. For musculoskeletal back pain can be presented to clinic on joint pain. For back pain, if patient associated with headache or over 50 years, or you have suspecting any history of sensory deficit, so it's a red flag. For joint pain, fever, considered a red flag. If patient had history of joint pain plus fever, better to be further evaluated. Environmental heat injury, already we are talked about in the previous lecture. For trauma, numerous accident and injury face Hajj pilgrims, such as falling, sliding, traffic accident, and it's accounted 9.4% of hospital admission. It's mainly hospital job, not the ambulatory care service. It's only if it's minor one and can be only need cleaning and dressing and topical antibiotic and can be evaluated in the clinic. Otherwise, if you suspect any major trauma, better to be further evaluated. Thank you so much, and I hope also it's informative.
talk. Dr. Abdulaziz Basha, he is adult hematology consultant in the Women's Hospital, the director of the hematology department in Mater Nestor, and the program director for the internal medicine residency program in non-specialist hospital. Please welcome Dr. Basha.
الله يعطيك العافية. شكرا. أنا أحتاج إني أوقف هنا بس. لا it's okay just a moment. طيب تمام. يعني ما هي فيديو. أقصد ما في كاميرا ولا شيء. أوكي بس يعني no need إنه تستعمل. طيب ماشي الله يعطيك العافية. طيب السلام عليكم ورحمة الله وبركاته. شكرا لكم جميعا الله يعطيكم العافية. شكرا دكتور عبد المجيد إتاحة الفرصة لنا إنه نكون بارت من الإدوكيشنال بروجرام هذا اللي إن شاء الله بإذن الله يعود للفائدة إن شاء الله لجميع الناس الاتندنس سواء فيزيكالي أو أونلاين أو على اليوتيوب. طيب I know إنه my lecture it's the last lecture so حبيت إنها تكون interaction أكثر من إنها تكون just data. medical emergency في الحج له معايير وconcerning أخرى عن أي شيء ثاني بنقابله في حياتنا اليومية طول الموسم. طيب أنا محاضرتي كانت تخص بالأخص يعني الإمرجنسي اللي بنشوفها في الحج a lot of times في المستشفيات سواء في emergency كإمبيشنت. في بعض التحديات اللي بتواجهنا مع الحجاج in general. طيب اول تحدي بيواجهنا اللانجوج. طيب نحن كثير بيشنت بيجونا سواء في الاي ار او حتى بنشوفهم في انبيشنت. طيب تيجي تحاول انت تتكلم معاه ما تقدر تفهم منه anything. بيكون في language barrier وحتى لو في attendance ولا اي احد حواليه ما تقدر تفهم منه a lot of things. فهذه احد التحديات اللي انت you have to think انه to get the diagnosis by less information. ايضا برضه من التحديات انه يجيك بيشنت كبير في السن عنده a lot of comorbidity لكن ما عندك report for his clinical data. انا اقدر based on it اعرف البيشنت هذا ماشي على ايش بياخذ ميديكيشن ايش حصل له، لا اني انا اقدر اتكلم معاه ولا انه هو حتى كثير من الحجاج بيجوا ما عندهم ميديكال ريبورت لحالاتهم. فهذه من التشالنج للدكتور او للنيرسز او اي ميديكال ستاف لما بيواجه الحاجي انه يقدر يتصرف ويتعامل معاه. ايضا من التحديات اللي بنشوفها في الحج طيب اسامي الميديكيشن مع الحجاج كثير بيجوا من دول مختلفه، فتلاقي لما يجي يوريك الميديكيشن تلاقي الاسامي غريبه ولا انت عارفها وتنكتب باسامي بلده. فيجيني بيشنت مثلا هايبرتنسيف بيوريني الميديكيشن اللي بياخذه ويكون مثلا خلص، فعليا انا ما اعرف ايش هذا الميديكيشن لانه مكتوب مثلا باللغه التركيه باللغه فرنسيه او وات ايفر. فهذه احد التحديات اللي بتواجه الطبيب او الممرض او الميديكال ستاف انه just to know what he is on. طيب ايضا من التحديات انه a lot of حاجه بيشنت هم بيجوا they want to do فريضه الحج. طيب فتلاقي انه البيشنت بيجيك ويكون عنده something serious ومع ذلك هو يكون رافض تمام انه to be admitted to the hospital بحكم انه هو يخاف انه لو ممكن تروح عليه فريضه الحج. فهذه احد الكومن تشالنجز اللي بتواجه كل الميديكال ستاف خاصه مع الحجيج. احب انبه على نقطه انه ماي ليكتشر تخص الحاجات اللي لها علاقه بالحج. افتراضا لو انا مثلا بتكلم فور هايبونتريميا على سبيل المثال، انا ما راح اتكلم about pathology of hyponatremia او ايش الكوزز حقت الهايبونتريميا، لا انا بتكلم عن الحاجات اللي ممكن الحاجي تسبب له هايبونتريميا، الكومن سيناريوز اللي ممكن الحاجي بيجي بيها بالكومبليكيشن هذه. طيب فحاب انبه عشان لا توصل المسج بطريقه خاطئه. طيب هناخذ لفه سريعه على the most common systems وكل سيستم ايش الموست common disease اللي بتيجي في مع الحاج. اول شيء بنروح للكارديولوجي سيستم. طيب الهارت فيلير وديكمبنسيتد كارديومايوباثي واحده من الحاجات الكومن اللي بنشوفها في مستشفياتنا during الحج تايم. طيب ليش الحجاج بيخشوا في exacerbation heart failure او pulmonary edema؟ الحاجات اللي بتسبب لهم exacerbation للسيمتوم، البيشنت دائما بيخشوا في ستريس في تيكيكارديا. ليش؟ لانه بيجوا بيبذلوا a lot of اكسرسايز، مشي، بيروح يسوي عمره، بيتحرك، بيحاول يلف في مكه. هذه الحاجات مع التكيكارديا وهم كبار في السن فبتدخلهم في بالمونري ايديما. uncontrolled hypertension. طيب الانكنترول هايبرتنشن يجيك البيشنت، وحنشوف قدام اسباب البيشنت اللي بيخليهم او الحجاج بيكون البلد بريشر عندهم انكنترول، ولكن نحن نعرف كلنا انه انكنترول هايبرتنشن احد الحاجات الرئيسيه اللي بتدخل البيشنت في بالمونري ايديما. ايضا ischemic heart disease, acute insult of ischemic heart disease can be taking the patient to the heart failure. ايضا اذا كان البيشنت اصلا بياخذ كاردياك ميديكيشن، طيب ونعرف كاردياك ميديكيشن الوت، لكن بيوصل هنا تكون هذه الميديكيشن اكسبايرد ولا خلاها في الشمس وانخربت، طيب وات ايفر، لكن هي لوس هيز ميديكيشن، فهو وقف الميديكيشن فدخل في السيمتوم. انفكشن، كثير من البيشنت بيجوا عندنا هنا بيخشوا كبار في السن، بيخشوا في ريسبيراتوري تراكت انفكشن، اتس ان باي بالمونري ايديما. فانا بقول لكم هذه المسجز اللي ممكن البيشنت بسببها يخش في بالمونري ايديما اور ديكومبنسيتد هارت فيلير. عادة السيمتوم اللي حتجينا اذا البيشنت كان عنده ديكومبنسيتد هارت فيلير ولا بالمونري ايديما، الكومن سيمتوم اللي نعرفها ديزنيا، اورثوبنيا، لور ليمفيديما، اي ثينك انه الاغلب يعرفها. How to treat patient with pulmonary edema or heart failure or decompensated، هو المين تريتمنت از diuretic، لكن يعني just انت في الاي ار ولا ان بيشنت يو هاف تو تيك ذا اوبينيون اوف كارديولوجي. ليش؟ البوينت منها انه جست انت لما تعرف السبب وهذا الحاجه ليه دخل في هارت فيلير، مو بس انا اديله دايوريتك، لا انت يو هاف برضه لو البيشنت خسر ميديكيشن فانت يو هاف تو جيف هيم هيز ميديكيشن. لو بياخذ دوز ما هي مناسبه لازم الكارديولوجي يعدل له الدوز حقته مظبوط. لو البيشنت عنده خلينا نقول انفكشن وي هاف تو تريت الانفكشن. طيب ف اتس نوت جاست دايوريتك والبيشنت تقول له مع السلامه وروح وكمل حجك، لا يو هاف تو جاست تو سي واي هي از جوينج تو هارت فيلير وتراي تو تريت. طيب المشكله الثانيه في الكارديولوجي كثير من البيشنت بنشوفهم بان كنترول هايبرتنشن. طيب ليش البيشنت الحجاج بشكل عام بنشوفهم في اليار ولا في الان بيشنت بان كنترول هايبرتنشن؟ موست اوف ذيم اول شيء نفس الريزن اللي ذكرته قبل شوي، انه تلاقي الادويه حقته خلصت، طيب او جاء وقاعد في الشمس وانخربت. طيب كمان الستريس هذول الحجاج وخاصه الكبار في السن تلاقيهم طول الوقت هم ماشيين برا، يروحوا الحرم مشي، يخرج يسوي عمره، يحاول يمشي في المزارات، طول الوقت ماشي، وهذا الشيء بيسويه في تيكي كارديا ويدخله في ستريس فبيرفع له بلاد بريشر. البين نفس الحكايه، تلاقيه ذا اند اوف ذا داي كبار في السن جسمه كله يوجعه ولا مصدع ولا تعبان، البين اتسلف كان انكريز بلاد بريشر. هذه الحاجات خاصه اذا جاك بيشنت بان كنترول هايبرتنشن سواء في الاي دي ولا في الان بيشنت، جست كيب ات ان يور مايند، لانه هذه كومن سيناريو بتيجي في الحج. انفكشن ان جنرال، اي انفكشن في واحد اولد ممكن يرفع له بلاد بريشر. طيب فاي بيشنت يجيك الاي دي ويكون البلاد بريشر حقه هاي، just take a look simply within 1 minute why the patient he have uncontrolled hypertension and just treat that cause. الناس اللي يكون عندهم uncontrolled hypertension عادة hypertension is asymptomatic، ولكن لو كان في symptom عادة لما يكون بالر فيجن or headache أو لا قدر الله ممكن يخش في hypertensive encephalopathy ويكون البيشنت عنده decreased level of consciousness. أتمنى بس تخلوا بالكم من موضوع لو جاكم البيشنت بهاي blood pressure بس you have to rule out الهايبرتنشن emergency. واحدة من الحاجات اللي it's emergency and critical. طيب نحن كيف نعرف الهايبرتنشن emergency؟ يكون blood بريشر هاي بلس يكون عنده يا سي ان اس سيمتوم ولا كاردياك سيمتوم ولا رينا. السمبل جست وما تاخذ منك 1 مينيت. واي انا بقول لكم هذا الشيء؟ لانه الواي اوف تريتمنت از ديفرنت. لو هذا بيشنت عنده هايبرتنشن ايمرجنسي اي هاف تو تريت هيم وذ اي في ميديكيشن صح، لكن لو كان عنده هايبرتنشن ايرجنسي ما عنده اي شيء من الثلاثه هذول اتس سيفلي، وانا في الطوارئ اقول له تفضل روح ارجع مع حملتك بس وات وي نيد just to adjust the dose ولا add some medication. طيب فايتس فيري امبورتنت تو رول اوت هايبرتنشن ايمرجنسي فروم ذا اي ار. زي ما قلت لكم كيف نعالج؟ there is clear guideline for hypertension. you can add, you can increase the dose whatever. كل واحد عنده his own school، لكن just my advice والشيء الباد براكتر اللي بشوفه خاصه في الاي ار انه كثير بيشنت بيجوا بهاي بلاد بريشر ما يكون عندهم اي سيمتوم ثانيه. كثير من الدكاتره للاسف بيعطوهم اي في ميديكيشن بيخرجوهم ويقولوا لهم continue your medication. طيب وتلاقي البيشنت بياخذ الاي في بينزل بلاد بريشر for hours وبعد كده بيرجع مره ثانيه يرتفع، ممكن بعد كده لا قدر الله يخش في complication. This is not the true practice. Patient جاء with hypertension urgency just treat him with oral. طيب no need to give him IV، لكن you have to add your touch. اما تقول له كمل على الميديكيشن حقتك and that's it no. طيب وات اباوت بالمونري؟ حاجات كلها اللي بنشوفها في الريسبيراتوري ديزيز الازمه. ليش الحجاج بيخشوا في ازمه؟ يعني انفكشن طيب سمبل upper respiratory tract infection انفلونزا اي انفكشن ممكن يدخل البيشنت في exacerbation للازمه. طيب كثير بيشنت بيجوا هنا واجتهادا منهم بياخذوا ميديكيشن من نفسهم من راسهم. يجي مثلا مع المشي كثير رجله وجعته وقوم someone advice for him مثلا انسيد، فتلاقي a lot of patient بياخذوا ميديكيشن ويكونوا هم الرجيك له وهم ما هم عارفين هم بلد غريب فبيخشوا في exacerbation. فسيمبلي باي هيستوري ممكن تساله تقول لو جاك بيشنت تقول له انت اخذت نيو ميديكيشن في الايام الماضيه، فسيمبلي ممكن يكون نهايه القصه بسبب ميديكيشن. طيب اجين زي ما قلت لكم ممكن البيشنت تيجي بخاخه من هناك ضيعه خلص عليه واتفر ما بياخذ وقف الميديكيشن حقته فجاك باكسسربيشن. environment طبعا كثير من الحجاج بيجوا بيروحوا فنادق دي مخدات اسره لحاف كلها حاجات فيها احيانا تكون غبره فيها بعض الماتيريال اللي ممكن irritation respiratory symptom. فلما يخش لنا حاجه it's not just to give him treatment وانا ما اعرف what's going on. ممكن اوكي انا اديله asthmatic medication لكنه عنده مثلا infection وانا I'm not treating، صح ولا لا؟ ممكن يكون هو ميديكيشن حقته خلصت و simply just what he need من اللي just to give him some medication and he will be fine. ف simple tricks ممكن يعني توضح الصورة كاملة للناس اللي يجوا باكسسربيشن ازمة. طبعا السيمتوم كلكم عارفينها غالبا بيشنت لو جاك wheezing كاف productive كاف night كاف shortness of breath history of asthma. طيب I think most of you تعرفوا الازمة exacerbation. مهم جدا يا شباب انه ناخذ خاصه نحن في موسم حج انه جست ريفيو جايد لاين هاو تو تريت الازمه سواء في الاي ار ولا في الانبيشنت. مهم جدا ان نعرف البيشنت لما يجيني بازمه how many session I have to give him. للاسف كده بس اللي بنعرف في الامرجنسي عندنا بيكون باي رونج واي بيعطي البيشنت 1 سيشن بعد كده ممكن يخرج البيشنت ولا ينومه ولا يدخله اي سي يو. نحن نعرف انه الحج تايم اتس كريتيكال في كل الاي سي يو او الانبيشنت. فنحن وي هاف تو جيف ذا بيشنت ذا رايت واي تو تريتمنت. نديله 1 بعد كده ننتظر ما في ريسبوند ندي 2 ما في ريسبوند ندي 3 افتر ثيرد وي هاف تو ري اسيس اجين ونشوف بعد الثيرد نشوف هل البيشنت ده كان بي جو هوم اور نيد تو بي ادميشن ان ميديكال وورد ولا تو ذا اي سي يو. فهي حاجات بسيطه وي هاف تو ريفيو ات عشان ممكن الجود مانجمنت يريحك ويريح يعني يقلل الريت اوف ادميشن وفي نفس الوقت سيفنج تو ذا حاج. طيب في تريكات بسيطه ممكن من الاي ار انا عارف انه هذا البيشنت كريتيكال وممكن حتى يحتاج انتوبيشن. هذا موسم بنشوف فيه حجاج يجوا بازمه بعدد مهول خاصه مع الحراره الشديده واحيانا بتنزل علينا مطره والغبر ونحن مكان صحراوي. طيب ف it's very important لنا كميديكال ستاف نتعامل مع حاجه بيشنت جاست تو ريفيو الجايد لاين تبع الازمه. جاسترو اول شيء فوميتنج. كثير حجاج بنشوفهم في فتره الحج بيجوا فوميتنج، صح؟ فوميتنج لما يجيني البيشنت بهيستوري اوف فوميتنج طيب اي هاف تو نو عشان لما باخذ منه هيستوري ايش الموست كومن هو كحاجه الحاجات اللي ممكن تسوي له فوميتنج. طيب الكومنست از جاسترايتس. بيشنت بيجوا من برا بياكلوا طعام غريب عنهم ما هم متعودين عليه فالوت اوف ممكن بيصير لهم زي الاريتيشن في الاستمك فتكون السمبل جاسترايتس. again a lot of medication ممكن تعمل جي اي ابسيت وكم منها اسبرين الانسيد وكثير من البيشنت بيجوا بياخذوا هذه الميديكيشن بشكل فريكوينت فهذه الحاجات بتعمل لهم irritation ممكن تسوي لهم فوميتنج. طيب فود بويزنينج ونحن في حج سيزون ومتوقع انه نشوف حالات كثيره بفود بويزنينج فجست كيب ات ان يور مايند لما يجيك بيشنت بهيستوري اوف فوميتنج دي كي اي واحد من السيمتوم اللي البيشنت بيجي بيها بيكون عنده دي كي اي vomiting. فإذا جاك البيشنت by history of diabetes وجاك ب frequent vomiting just keep in mind could be this is DKA. Okay. UTI خاصة all patient الناس الكبار في السن by simple UTI بيجيهم GI symptom ممكن يجيهم nausea vomiting حتى diarrhea. Okay. أي viral infection نحن بنشوف كثير من الناس بيجيهم دنجي. نحن في موسم دحين مليان الدنجي فيه كثير بيشنت بيجوا GI symptom nausea vomiting ودايريا فجست keep an eye أي viral infection. الفكرة منها إنه مو just أنا يجيني patient by vomiting treat the vomiting and that's it. I have to know why the patient have vomiting. Okay. حاجات simple يا جماعة يعني إحنا just يعني أنا I keep it هنا إن حاجات اللي related للحج season. Okay. طبعا لما يجيني patient by vomiting it's very important just to assess الهيدريشن للبيشنت. ومو بس الهيدريشن، كمان it's important to know if the patient can take oral ولا لا، لانه هذه من الحاجات اللي to guide me if the patient need admission or not. طيب لانه زي ما قلت لكم من البدايه الاي دي فيزيشن ممكن له دور كبير جدا في المحافظه على البيد كاباسيتي في موسم زي موسم الحج اللي كل الاقسام تحتاج البيد فيه. فاذا كان انا الديسيجن حقي صح فانا بساعد الاذر ديبارتمنت في موضوع البيد كاباسيتي. طيب فدائما البيشنت جاست اذا البيشنت جاني frequent vomiting I have to assess he can take orally ولا لا، هل البيشنت عنده severe sign of hydration ولا لا، هل البيشنت عنده comorbidity، هل البيشنت عنده other association symptom ولا لا. and even حتى يعني نحن احيانا براكتس كثير بنشوفه يعني اكثر الاي دي فيزيشن لو جينا سالناهم ايش الميديكيشن اللي تعطوه فور فوميتنج اعتقد 90% يمكن ما يعرفوا غير بلازيل ميتوكلوبرومايد. لا نحن عندنا a lot of choice ثانيه. فاي ثينك انه this is the good time انه just review انا ايش عندي other medication as anti-emetic I can use it. طيب لانه بيجوا البيشنت بيدي بلازيل مثلا ولا ميتوكلوبرومايد ويخرجوا. طيب وبعدين still frequent vomiting it's not stop. طيب it's very important just to take time and just review your option and patient can take orally or IV. هذه حاجات simple لكن في الحج بنشوفها بشكل frequent. ف this is I think it's good time just to review it. طيب ايضا الدايريه is very common بنشوفها في الحج سيزون. الموست كومن طبعا زي ما انتم عارفين gastroenteritis. هذول الحجاج نحن لو سافرنا اي مكان 80% من الناس اللي بيسافروا anywhere بيجيهم gastroenteritis وبيجيهم دايريا. ف it's very common انه يجيك بيشنت لي خاصه اول بدايريه ويكون عنده dehydration. ايش كمان في حاجات بتسوي دايريا medications. a lot of medication can cause صح. في ناس بيجوا في البدايه يكون مثلا عندهم constipation مع طبيعه الاكل ومع الميديكيشن فتلاقيه he doesn't know someone gave him lactulose فتلاقيه قاعد يشرب فيه ويجي دايريا symptom association symptom لكن يكون just بسبب ميديكيشن هو اخذه. طيب ف it's very important just to know why the patient have diarrhea. كثير من البيشنت بيكونوا already known cause يعني already known of IBS. طيب ومع الاسترس اللي في الحج والقلق والتعب ممكن يخش في exacerbation من الاي بي اس. ونحن نعرف انه الاي بي اس واحد من التايبس حقتها انها ممكن تبرزنت الدايريه. طيب مهم جدا لما تعمل اسسمنت للبيشنت الدايريه just simple to know how many times he get diarrhea عشان انا كان اسس السكيورتي just لما اساله كم مره انت بتجيك الابيسود هذه. طيب ومهم جدا اعرف الكونتنت حقتها از بلادي ولا لا لانها تفرق معي في المانجمنت. اوكي هل يحتاج انا اعطي انتي بايوتيك ولا just supportive treatment وفلويد and that's it. اوكي انا يعني لاحظت انه كثير من الدكاتره والتمريض ما يعرفوا هذا الميديكيشن اللوبرامايد it's very well known medication بيستخدم كثير. هذا انتي دايريتك. طيب وموجود ورخيص يعني ب4 ريال في الصيدليات. طيب وبيستخدم الى 6 مرات وطريقه استخدامه انه تكون افتر ابيسود اوف دايريا يعني بعد المريض ما يخرج من الحمام ياخذ هذا الميديكيشن لكن بشرط انه ما تكون الدايريا بلادي. اوكي فكثير بيشن بيجيهم جاسترونترايتس سمبل جاسترونترايتس فايرال. اوكي ويكون حاج كبير في السن وكل شويه رايح الحمام انت تقدر تخففه من هذه المعاناه just prescribe for him loperamide. It's 4 milligram you can give him until 6 times per day. طيب it's good time just to know about this medication. abdominal pain is very common symptom بنشوفها في الحج. لما يجيني البيشنت بابدومينال بين just I have to think هو حاجي ممكن الحج يرتبط بابدومينال بين. gastritis زي ما قلنا simply can cause peptic ulcer disease بسبب الفود ونوع الفود اللي بياكلوه هنا. ممكن irritation للبيبتيك ulcer رجير IBS pancreatitis hepatitis I mean hepatitis A. اوكي it's food related وسيمبلي بيجي بسيفير abdominal pain just لو جاك بيشنت الاي دي ما عندك clear explanation just ask for liver enzymes and check لو جاك high liver enzyme think about hepatitis A. DKA زي ما قلنا اول can present with vomiting برضه simply can present with abdominal pain. لو جاك patient with diabetes and abdominal pain think about DKA. Medication a lot of medication can cause abdominal irritation. Calcium tablet, iron tablet, aspirin, NSAID وغيرها. A lot of medication simply can irritate the abdomen ويجيك البيشنت بابدومينال pain and simply it's just drug related. اوكي يوريميا خاصه في الناس اللي هم already على dialysis just keep in mind لانهم بيجوا هنا السيشن حقت الدياليسيس حقتهم بتتاخر قبل ما يتظبطوا لهم قبل ما الرينج، فتلاقي انه هو تاخر الرينج بتدو فور دياليسيس، فتلاقي اليوريا بترتفع عنده، بيجي له بابدومينال بين ونوزيا، بيجيك البيشنت اللي باي سيفير ابدومينال بين and the reason is uremia. اوكي، هايبركالسيميا واحده من الحاجات اللي كومون كان كوز ابدومينال بين، وتغيب كان كثير من الميديكال ستاف انه يجيني البيشنت ما عنده اي كلير كوز، لكن في الاخير اند باي. فلو جاك البيشنت عنده سيفير ابدومينال بين وانا ما عندي كلير كوز just ask about calcium level and check. طيب فممكن يكون هو الريزون. اوكي، بس زي ما قلت لكم this is always medical. don't forget انه just to rule out acute abdomen خاصه لو الابدومين is very tender. اوكي، ناس كثير للاسف انها بتتجاهل موضوع انه الانالجيزيا، وهذول حجاج. طيب فانا بشوف كثير من الناس انه هي از انفستيجيتد، تلاقي البيشنت بيقعد في اليار بالساعه والساعتين والثلاثه، بيرسلوا يقول له استني نسوي تحاليل، نرسل لك السي تي، خلي السيرجن يشوفك، وساعتين ثلاثه البيشنت بيفرفر من البين. طيب ولا تلاقي الدكتور الله يهديه يعطي له باراسيتامول، يقول خلاص انا اديتك باراسيتامول ما انا اسوي لك، هو البيشنت حيقول لك انت ايش تسوي لي؟ طيب فدائما نحن بنكون الصراحه تريشوت حقنا از ريسبوندينج للبين از فيري ويك. فتذكروا دائما انه هذول ضيوف الرحمن، ضيوف الرحمن. يعني اذا انت ريحته من الالم حيدي لك دعوه، الله اعلم انت ايش ممكن يعني ربنا يفتح عليك بسبب الدعوه دي. don't just neglect him وتقول له والله what I have to do، اديتك باراسيتامول الم ما سكت ايش اسوي لك؟ لا، just interfere حتى لو اضطريت تدي اوبيويد just give him relief him from the pain. اوكي، نروح لحته ثانيه، نيفرولوجي ديزيز. اوكي، موست كومن بنشوفه في الحاجز يو تي اي صح، وخاصه في الناس اللي هم كبار في السن السمبلي تقول يو تي اي صح. وزي ما قلت لكم اليو تي اي لها خاصه في الكبار في السن، ممكن البيشنت حتى يجيك بديكريز ليفل اوف كونشسنس. يا ما شفنا اول بيشنت بيجوا بديكريز ليفل اوف كونشسنس، ونفكر في حاجات اسكيميا ولا ام اي ولا وات ايفر، وفي الاخير اتس اند باي سمبل يو تي اي. اوكي، سو لو جاني بيشنت بيو تي اي ايش موست كومن سيمتوم حتكون؟ ديسيوريا، هيماتوريا، انكونتيننس، ممكن واحد وممكن 10 مع بعض. طيب يعني سمبلي ممكن جست البيشنت يجيني بجي اي سيمتوم، جي اي سيمتوم اتس ان باي ديسيوريا او يو تي اي. طيب فهذه كلها احد اعراض اليو تي اي. طيب طبعا how we are treating a UTI اوكي باي انتي بايوتيك. طيب ولكن برضه just keep an eye، احنا عندنا a lot of option في الانتي بايوتيك. طيب ف يعني try to choose your antibiotic based على الايج related. It's the most common medication الناس بتستخدمه في اليو تي اي. دائما try to avoid it في الناس الاولد. اوكي، في a lot of medication antibiotic بتسوي جي اي symptoms زي مثلا زيترو على افتراض، واحد من الميديكيشن بيستخدم في اليو تي اي. طيب فانت دائما يو ار دكتور اوكي اور نيرس اور اي ميديكال، تراي انك تربط الموضوع ببعض، لا تعطي البيشنت ميديكيشن يسوي جي اي سيمتوم اوريدي البيشنت جاي ب جي اي سيمتوم. اوكي، ولا تعطي البيشنت ميديكيشن ممكن يسوي له سي ان اس سيمتوم اوكي هو يكون اول. طيب no harm to ask, no harm just to take a look. في دحين احنا زمان اختلف عن زمان كان عشان اي احد سواء في الانبيشنت ولا في الاي دي عشان to get medical information لازم يروح يبحث ويفك كتاب وياخذ وقت طويل عشان يبحث. الان انت اي تحدي بتواجهه في الاي دي ولا في الانبيشنت جست ما حياخذ منك دقيقه انك جست تشغل جوالك وتبحث ان شاء الله في جوجل. اوكي، ايوه طبعا don't forget انه يعني ما هو بس انه انا عندي بايوتيك واقول له يلا مع السلامه. لو البيشنت عنده جي اي سيمتوم ادي له حاجه فوق الجي اي سيمتوم، لو عنده بين ادي له انالجيزيا. طيب لا تدي كثير للاسف بيعطي انتي بايوتيك ويمشي الحاج بيته بدون ما ياخذ في الاعتبار الاذر اسوشيشن سيمتوم. طيب الان حمر على السريع بالوت اوف الكترون ديستيرب اللي بنشوفها كمان مع الحجاج في فتره الحج. ايش اسبابها؟ زي ما قلت لكم من البدايه حج ريليتد. I'm not talking about pathology of hypernatremia or اي electrolyte disturbance. انا بشوف ايش الحاجات اللي تكون مع الحجاج كومن بتدخلهم مثلا في هايبرنتريميا. اول شيء ايش السيمتوم حقت الهايبرنتريميا عشان لو انا مثلا كنيرس ولا دكتور جاني بيشنت باي حاجات من هذه السيمتوم جست تو نو لانها تفرق معايا حتى في المانجمنت بلان. طيب البيشنت اللي يكون عنده هايبرنتريميا ممكن يجي ب any one of these، ممكن يجي بمسل ويكنس، restlessness، confusion، irritability، seizure، اوكي unconscious. فلو جاك patient with decreased level of consciousness واحدة من ال most important differential diagnosis look for any electrolyte disturbance وغني منها الهايبرنتريميا. طيب ليش البيشنت ممكن في الحج يخش في هايبرنتريميا؟ طيب water loss. طيب البيشنت اذا خسر سوائل من جسمه حيخش في هايبرنتريميا. طيب كيف حيخسر سوائل؟ بيمشوا في الشمس كثير فطبيعي بيعرق، لما بيعرق ممكن يخش في هايبرنتريميا لانه الصوت بيتخزن في جسمه. طيب لو عنده سيفير دايريا وفوميتنج ممكن يخش سيمبلي في هايبرنتريميا لانه بيخسر فلويد. اوكي. يورين، البيشنت اللي بياخذ دايوريتك كثير لو دخل في دايابيتك انسيبيدس، ولا البيشنت جاك هنا وما اخذ الميديكيشن حقت الدايابيتس وصار ان كنترول وصار بيخش الحمام كثير، سيمبلي هي از لوست فلويد. فهذه الحاجات كومن في الحج وممكن تدخل البيشنت في هايبرنتريميا. اوكي. واحده من الباد بيهيفير في الحج ممكن اتكلم عنها الاخوان في الهيت ريليتد النس، الهايبرنتريميا ريليتد للهيت النس. اوكي. عندهم الحجاج عندهم ثقافه كثير انه حاول تشرب مويه كثير عشان ايش؟ عشان ما تخش في دي هيدريشن، صح؟ فتلاقيه طول الوقت يشرب 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 مويه، لين ما انقلبت الايه بالعكس فصار في مخزون صوت كثير في جسمه بسبب المويه اللي بيشربها، فصار دخل في هايبرنتريميك. طيب وممكن يجي بسيفير سيمتوم، ممكن لدرجه انه يدخل في decreased level of consciousness. اوكي. طبعا نحن sometimes لما بيشنت حجاج بيجوا بهايبرغلايسيميا وتريتنج الهايبرغلايسيميا irreversible بيرتفع الصوديوم ليفل عنده. اوكي. كيف نعالج؟ كل الالكترولايت ديستربنس فيها تشالنج مره كبيره في الحج، اللي هي انا ما اعرف هذا البيز لاين حقه ولا this is something acute. طيب لانه زي ما قلت لكم في البدايه ما بيجيك ميديكال ريبورت، انا ما اعرف ولكن احنا وانس انه البيشنت بيجيني بسيمتوم لهذا الشيء I have to treat with him like acute. اوكي. طبعا المين جول اوف تريتمنت في حالات الهايبرنتريميا انه جست زي لو انت عندك مثلا كاسه فيها ملح شديد، انا عشان اخفف الملح اللي في المويه حزيدها مويه، بس بشرط المويه دي ما تكون فيها ملح، يعني ما اديله نورمال سلاين. نورمال سلاين فيه له صوديوم، صح؟ انا تراي ماي بيست انه تو افويد الصوديوم. اوكي. عشان كده في الاكيوت نحن دائما بنستخدم دي 5 ووتر، ودائما بيشوفوا يقول لك والله اورال ريستريكشن. هي الفكره مو انه انا اعطشه، الفكره انه اديله حاجه، لو قدرت انا اوفر له مويه بأقل صوديوم ليفل this is very good for him. اوكي. كثير يا جماعه حنشوف حالات electrolyte disturbance بجميع انواعها، ف it's very important in this time just to take a look a review about approaching مثلا حالات for hyponatremia ولا حتى ال other electrolyte disturbance. اوكي. hyponatremia again the symptom ترى الهايبر والهايبو كلهم كان present with CNS symptom. اوكي. وكلهم ممكن يدخلوا البيشنت في كوما، وكلهم يسووا سيجر، وكلهم يسووا مسل ويكنس. كسيمتوم وايز الهايبو والهايبرنتريميا اولموست سيم، ما بيختلف السيمتوم وايز كثير. اوكي. ليش الحاجه ممكن يخش في هايبونتريميا؟ لو جينا نفتح الهايبونتريميا كابروش حتلاقيها صفحات. طيب هايبوفوليميا، نورموفوليميا، هايبرفوليميا. ما this is not our area just to discuss all of this، لكن I'm just to think why the patient he will يعني most common انه can go to hyponatremia. the main symptom the main things hydration من الانفكشن، لانه زي ما قلت لكم قبل كده هذول بيشنت كثير بيخشوا في انفكشن، فطبيعي مع الدي هيدريشن بيخشوا في hyponatremia. اوكي. medication a lot of medication ممكن تسوي لهم hyponatremia. اوكي. الهارت فيلير بس one من الكوزز حقت الهايبرفوليميك، ولكن simply why it's important لانه treatment يا جماعه is totally different. أنا وجاني hyponatremia secondary heart failure my management is totally different than patient hyponatremia from hydration. But it's very important just to أحط صباعي على الكوز، بعد كده treatment it will be very easy. Okay. Again how we are treating is very important to know من ال ER نفس الحكاية الكلام اللي بنقوله كل مرة. أنا لازم أعرف assess السيفيريتي، البيشنت لو عنده symptom severe symptom or not، كم الليفل حق الصوديوم. اوكي. هل البيشنت ده يحتاج ادميشن or not؟ سمبلي لو البيشنت جاني مثلا عنده هايبونتريميا سكندري هايدريشن، سمبلي من الاي ار انا كان جيف هايدريشن اقول له بعد كده خلاص ممكن تروح بيتك، صح ولا لا؟ لكن لو كان البيشنت جايني بهايبونتريميا وعنده سيفير هارت فيلير وعنده فيري سيفير سيمتوم، هذا البيشنت ما اقدر اخرجه. ممكن البيشنت الاول كليفل حق هايبونتريميا اكثر بكثير من الثاني، لكن الاول اخرجه بيته والثاني لا، صح؟ عشان كده it's very important انك انت تعرف الكوز حقت الهايبونتريميا. طيب وبعد كده انت باي مانجمنت تقدر تقرر اذا simply I can discharge him home or I have to admit him. هايبركاليميا It's very common بنشوفها برضه من الحاجات اللي common بنشوفها مع الحجاج في موسم الحج. اوكي patient لو عنده هايبركاليميا most likely he will present with what? palpitation, shortness of breath, chest pain, nausea, vomiting. اوكي ايش الحاجات اللي بتخلي الحجاج يخشوا في هايبركاليميا ميتابوليك اسيدوسيس خاصه لو كانوا سكندري اي رينال كوز ولا ديك البيشنت اللي يكون عندهم انسولين ديفيشنسي هايبرغلايسيميا هايبر، الناس اللي عندهم رينال فيلير. يعني الصراحه نحن كومن مع الحجاج ممكن تشوفهم في حالات الرينال فيلير اوكي وخاصه اللي على دياليسيس. اوكي ميديكيشن يس في سم ميديكيشن كان كوز ما هي كثير لكن بيتا بلوكر واحد من الكومن ميديكيشن اللي ممكن تخلي البيشنت يخش في هايبركاليميا. اوكي I think most of us اعرف كيف يعالج الهايبركاليميا. هذه ما هي مشكلتنا ولا قضيتنا ولكن again الهايبو والهايبركاليميا من الحاجات اللي ممكن لا قدر الله تعمل كاردياك ارست. اوكي فايتس فيري امبورتنت انه انا لما يجيني بيشنت بهايبو ولا هايبركاليميا simple thing just to do ECG. طيب just to be sure انه الهارت is fine. اوكي بعد كده انا اوكي ممكن اقول للبيشنت I can't treat him in the ER واخرجه ولا patient need to be admitted. اوكي ولا احيانا تعرفوا يعني ممكن يكون simple هايبوكاليميا الليفل يكون سبيري له حتى ما يحتاج اعطي ميديكيشن ممكن اقول له just diet. اوكي just diet كل اكل rich with potassium and that's it ما تحتاج اي شيء ثاني. فايتس very important just to assess السيمتوم في الهايبو والهايبركاليميا عشان نعرف السيفيريتي والديجري حقت البيشنت. اوكي ايش الحاجات اللي بتدخل البيشنت في هايبوكاليميا؟ again حاجات كومن بنشوفها في الحج زي الفوميتنج الدايريا الدايوريتيك الهايبوثيرميا خاصه الناس اللي هم مثلا تلاقيه كان ماشي في الشمس فتره طويله وبعد كده راح الفندق وقاعد في اللوبي ولا في غرفته مكيف فتره طويله فالهايبوثيرميا كان تيك هيم تو هايبوكاليميا. الناس اللي اوريدي على دايليسيس الناس اللي بياخذوا اللاكزيتيف بتصير لهم هايبو. الهايبومغنيسيميا والهايبوفوسفاتيميا كان كوز هايبوكاليميا. واجين زي ما قلنا في الهايبرنتريميا اللوس اوف سويتنج ممكن تسبب هايبرنتريميا وهايبوكاليميا. اوكي فthis is just simple thing associated مع الحجاج ممكن يدخلهم في هايبوكاليميا. اوكي اوكي طبعا منطقتي المفضله. اوكي الحاجات اللي ريليتد بالهيماتولوجي كم بنشوفها مع الحجاج. اوكي نمبر 1 بليدنج. اوكي لو جاني بيشنت في الحج was very common خلوا بالكم نحن في البليدنج دائما بنهرج على شقين is it hereditary ولا acquired. طيب hereditary حاجات هو اتولد بيها في حاجات نحن في السعوديه هنا ما هي common بنشوفها لكنها عند غيرنا common. طيب اللي عند غيرنا common بيجيك في الحج انت اوريدي ما تعرف تتعامل مع دي الحالات كثير لانك انت ما بتشوفها اصلا frequently طول السنه لكن هو بيجيك هذه الفتره فيها. طيب وممكن يتعرض لتروما وهو اصلا عنده هيريديتري ديزيز. طيب فيجيك الطوارئ ممكن لايف ثريتنينج بليدنج how you can deal with him. حنمشي كده على السريع يعني small trick ونفس الحكايه it's not our area just to take everything in detail لكن small point كده ان شاء الله تفيدكم وتضيف لكم معلومات ان شاء الله في الحج. لا قدر الله لو جاكم بيشنت طبعا نحن لما نقول acquired يعني most likely I mean medication mean what قديش حجاج بياخذوا انتي بليتلت بالكيلو صح ولا لا؟ قديش حجاج بياخذوا انتي كواجلانت بالكيلو؟ فكثير بيشنت بياخذوا انتي كواجلانت ولا انتي بليتلت وممكن يجيك الاي ار بلايف ثريتنينج بليدنج. سو هاو اي كان ديل وذ ذس. طيب الهيريديتري الموست كومن طبعا وورد وايد الفانول براند هو الموست كومن. طيب بعد كده فاكتور 8 فاكتور 7 فاكتور 9 وفي حاجات نحن جروب اوف اذر كواجليشن ديزيز نسميها رير فاكتور ديفيشنسي. اوكي الفانوال براند. طيب لو نحن نبهرج حتى على فاسيلتي عندنا في الصحه. اوكي لو انا جاني بيشنت الاي دي ولا في الام بيشنت بسيفيري بستاكسيس طبعا نحن عشان نكون برضه نوضح صوره احنا عندنا حاجه اسمها برايمري هيموستاسيس وسكندري هيموستاسيس. برايمري هيموستاسيس اي حاجه بتاثر في البليتلت باثولوجي. طيب في البليتلت ولا في الفانوال براند ولا في الابيثيليوم يعني انا لو جيت واحد سكينه شقيت له جلده هذه مشكله في البرايمري هيموستاسيس. اوكي طيب ده مين يا في الابيثيليوم ولا في البليتلت ولا في الفانوبراند. اوكي هذول كيف يجي السيمتوم حقتهم؟ نحن نسميهم ميوكوكاتينوس. ايش يعني ميوكوكاتينوس؟ سكين نوز فم طيب انال مينوريجيا. طيب حاجات ميوكوكاتينوس الاذرز اللي زي فاكتور 8 وفاكتور 9 هذه تيجي بديب تيشو بليدنج، يجي بسيفير هيماتوما انسايد، يجي بجوينت بليدنج. طيب فانا البيشنت السيمتوم حقتي تخليني انا افكر جوينت فين. ما يجيني واحد بسيفير بستاكسس واقول والله يمكن هذا عنده فاكتور 8 ديفيشنسي، لا. طيب الفاكتورات بتلعب في الاريا حقت الكواجوليشن. طيب الاذر ثينجز بتلعب في السكين وما حوالين السكين. اوكي طيب معليش انا حرجع. لو جاني بيشنت فان والبراند وجاني بسيفير بليدنج، هاو اي كان تريت وذ هيم؟ المفروض انه ادي ريبليسمنت صح؟ فان والبراند ريبليسمنت. اوكي طب انا في منطقه ما فيها هذا الشيء، كثير مستشفيات في مكه حاليا ما فيها الفاكتور. طيب ايش اعطي؟ هي الفكره ما فيها انه كمان البيشنت جاي ببليدنج والتايم اتس كريتيكال فور يو، ما ينفع انا اعطي حاجه ما فيها هذا الشيء ولا يكون بنسبه قليله، وهذا الشيء ممكن ياثر على حياه المريض وياخذ وقت منه صح؟ فلو جانا بيشنت فالنول براند ديفيشنسي وسيفير لايف ثريتنينج بليدنج وانا ما عندي الريبليسمنت، هعطي له حاجه اسمها ايش؟ كرايو بريفستيت. طيب تسمع انه كرايو بريفستيت هو عباره عن مركب بيستخلصوه من البلازما. نحن عاده بندي اف بي صح؟ هذا لما هم يجوا يعملوا سيبريشن للبلد بيطلع البلد فوق والبلازما تحت صح؟ وهذه اللي تحت هم الاف بي. البلازما هذه تحت كده في زي ترسبات كده بسيطه، هذه يسموها كرايو. هذه الكرايو بتحتوي على ايش؟ بتحتوي على الفانول براند، بتحتوي على الفايبروجين ليفل، بتحتوي على فاكتور 8 وفاكتور 13. اوكي هذه الاربع حاجات هذه مهمه عشان لو جاكم واحد بريبورت عنده فاكتور 13 ديفيشنسي وقاعد يصب، ما ادي له اف اف بي ومدري خلاص اروح دايركت ادي له كرايو. اوكي نفس الحكايه في فاكتور 8 ديفيشنسي، انا ما عندي الفاكتور، انا في سم سنتر بريفري وما عندي هذا الفاكتور ولا جنب الحرم ولا وات ايفر، اي كان ريبليس هيم وذ كرايو. اوكي طبعا اذا ما عندك حتى الكرايو ساعتها يو هاف تو بوش اف اف بي اند ذاتس ات. اوكي طبعا اذا جاك بسيفير بليدنج الناس احيانا بتنسى موضوع انه اي هاف تو جيف هيم بلاد، ما هو بس ادي بلازما، لا يو هاف تو جيف بلاد. البلد بيساعد في عمليه تحسين الهيموستاسيس. اوكي سو فانول براند ندي كرايو لو ما عندي الفانول براند ريبليسمنت. فاكتور 8 لو ما عندي الفاكتور اجين حاعطي كرايو. فاكتور 7 طيب اجين له اكثر ريبليسمنت ممكن يكون موجود في المستشفيات. طيب لكن لو انا في مكان برضه ما في فاكتور 7 اي هاف تو جيف اف بي. اوكي الاذر تختلف في جداول لها، يعني تعرف انه في بعض الفاكتورات لو انا عندي ديفيشنسي فيها سيمبلي اي كان جيف بليتلت بفاكتور ايوه زي فاكتور 5 موجود داخل بليتلت، فسم تايمز انا مو متوفر عندي الا بليتلت بوش بليت. طيب فهذه الكومون ثينكس اللي ممكن تشوفها في الحجاج بيجيك ببليدنج، فجست سمبل يو هاف تو تيك ا ديسيشن ناو. طبعا نو هارم انك تو اس لو عندك في السنتر حقك هيماتولوجي تيك هيز بوينت، لكن لو ما في عندك هيماتولوجي just take this point. طب لو جاني بيشنت بياخذ اسبرين وجاني بسيفير جي اي بليدنج، هذول اسمهم ايش؟ انتي بليتلت صح؟ فلو انا جاني بيشنت بسيفير بليدنج من انتي بليتلت وات ايفر كانت انتي بليتلت سواء بلافيكس اسبرين كلابيدوجريل وات ايفر، طيب give him platelet اوكي لا تقول لي والله انا اوقف الميديكيشن واوبزيرف واكلم الجاستر وما ادري، give him platelet. اوكي his platelet is dysfunctional. تقول لي platelet حقته 400، اقول لك this 400 dysfunctioning ما بتشتغل. مو بس كده، حتى البليتلت اللي انت حتعطي له هي حتشتغل شويه وحتصير dysfunctioning، لانه انا لو اخذت حبه اسبرين الان ل6 ايام قدام، 5 الى 6 ايام قدام انا ما بليتلت نوت وركينج، حتى لو سلي بليدنج وديتني البليتلت هيحاول يشتغل مره ثانيه لكن الميديكيشن حيروح يسيطر عليه وحيخلي البليتلت الجديده اللي اخذتها ديسفانكشن. لكن بدي مره ومرتين وثلاثه خاصه بحالات اللايف سيفنج اوكي وحالات اللايف ثريتنينج بليدنج. فلو جاك بيشنت ببليدنج وبياخذ انتي بليتلت، لانه هذول البيشنت حجاج وما عندهم جود هيستوري، فممكن طاح هو بيسوي عمره، ممكن خبطه باص، ممكن خبطته سياره، هو سكيميك وبياخذ انتي بليتلت اوكي وجاك فسيمبلي جاك ببليدنج ولا مروني ايش بياخذ ميديكيشن، لقيت فيه انتي بليتلت بوش بليتلت اوكي انتي كواغولانت. الانتي كواغولانت طبعا في انواع، حتلاقوا بيشنت طبعا حتشوفوا اصلا اسامي انتي كواغولانت غريبه ولا بنستخدمها في البلد هنا، لكن حيجوك حجاج بيستخدموها وانتهت. ياما وياما شفنا حجاج الى الان بياخذوا بدوبتران، حتى الريفلوكسبان فيري الناس الان بتاخذها. طيب ولكن ما اعرف انا حجاج بيجوا من جميع انحاء العالم ما اعرف هو ايش بياخذ، ولكن كيس فراني وجانب بليدنج وسيفير I have to know what I have to give. وارفرين الورفرين بس قبل ما اقول لكم حاجه، في معلومه هنا مره مهمه، لازم تعرف الهاف لايف حق الميديكيشن. بمعنى انه انا لو بيشنت جاني مثلا اخذ وورفرين وكان اخر دوز اخذها مثلا قبل يوم يومين ثلاثه، ده مين انه ستيل ميديكيشن ورك. طيب اي هاف تو جيف سمثينج اوكي. لكن لو بيشنت جاني مثلا بياخذ ابيكسيبان والله كان اخر دوز اخذها من يوم ولا يومين، ده مين انه ما يحتاج انترفير لانه الميديكيشن اصلا انتهى من جسمه. فانت ابسط سؤال واهم سؤال تساله في الهيستوري، متى اخر مره اخذت الدواء؟ اوكي. ليش؟ هذا الدواء دابيجاتران يعني يسموها ديالازيفايد. يعني ايش يعني؟ يعني بيشنت لو اخذ within 3 اور ممكن ارسله فور دياليسيس، والدياليسيس واشنج البلاد حقه، وذاتس فيري جود للبيشنت. طيب الميديكيشن الوحيد اللي انا I can send him for dialysis اذا اخذ الميديكيشن within 3 اور. after 3 اور ما حد ينفع الدياليسيس معه. طيب طيب احنا نهرج الان على الفاسيلتي اللي موجوده عندنا. لو جاني بيشنت بلايف ثريتنينج وبياخذ وورفرين I have to give him ايش؟ طبعا هو الجود طيب انه نحن ندي حاجه اسمها بي سي سي partial complex concentration، بس هذا ما هو افيلبل عندنا، نلاقيه عاده في الحرس وتخصص المستشفيات دي. لكن الافيلبل عندنا ممكن ندي فيتامين كي طيب سواء اي في او اورال طيب بلس اف اف بي. اوكي بلس اف اف بي. لو البيشنت جانب كليكسان ولا هيبرين again it's very important انه اعرف التايمينج. ليش؟ لانه الهاف لايف حق الهيبرين من 3 to 4 اور صح؟ لو جانب لايف سيفنج وهو الهيبرين اخذه قبل 6 ساعات 7 ساعات 8 ساعات ما يحتاج ادي انتيديوت اوريدي مشيت من دمه. طيب لا الكليكسان 12 اور 8 to 12 اور، فايتس فيري امبورتنت عشان انا اعرف I have to give antidote or not. البروتامين سلفيت هو الانتيدوت الكليكسان والهيبرين، عمله ضعيف مع الكليكسان ولكنه اسفيري افكتيف مع الهيبرين. طيب له دوز وله جدوله كذا معينه ما هو مجال ان اذكرها هنا، ولكن لو جاك بيشنت بلايف ثريتنج بليدنج بياخذ هيبرين ولا كليكسان ثينك اباوت بروتامين سلفيت. اوكي. الابيكسيبان واخواته اللي هم الريفلوكسبان والانتي 10 اوكي، هذول لهم انتي دوت بس لسه ما وصلت البلد ولكنها ابروف وفدي ابروف اسمها اندكسنت الفا. اوكي. حاليا ما هو متوفر عندي، لكن لو جاني بيشنت بليدنج وبياخذ ابيكسيبان ولا ريفلوكسبان اجين اف دي اي ابروف البي سي سي بس برضه ما هو موجود، فاللي افيلبل عندي اي كان ديل وذ ات اف اف بي. فلو جاك بيشنت ابيكسيبان ولا ريفلوكسبان ولا حتى دابيجتران، والدابيجتران في دواء اسمه ادراسيزوماب هذا انتي دوت للدابيجتران، بس كلها لسه ما هي متوفره عندنا في البلد. لكن عشان كان في معلومه زمان انه هذه الميديكيشن اللي كانوا يسموها الدواك ولا النواك ما لها انتي دوت، لا لها انتي دوت، لها انتي دوت واف دي اي ابروف بس لسه ما هي افيلبل. طيب حاليا اللي انا كان ديل وذ ات اف اف بي. فلو جاني اي واحد من دول اسال اول شيء عن متى اخر دوز اخذها، بعد كده اي كان ريبليس هيم وذ اف اف بي. اوكي. ثرومبوسيس كثير بنشوف بيشنت وذ ثرومبوسيس في الحج، كبار في السن عندهم كوموربيديتي كثير مع وضع الطيران، ما بيمشي كثير ما بيتحرك ما بيروح فجأة كده رجله انتفخت. اوكي. طيب انتوا تعرفوا ان التايمينج از فيري امبورتنت للحجاج دول، ومهم بالنسبه لهم كثير انه ما يصير له ادميشن. فانا لازم اخلي كرايتيريا عندي من الاي ار مين البيشنت هذول اللي يجي بنيو دي في تي يحتاج فور ادميشن، ومين البيشنت اللي اي كان سند هيم مع الحجاج واقول له روح كمل حجك امورك طيبه. طيب الناس اللي طبعا لو جاني بيشنت عنده سيفير سويلنج لدرجه عنده سيفير بين وما يقدر يحرك رجله، هذا البيشنت حرام انه انا اخرجه بيته، لانه بلس الانتي كواجولانت حيحتاج بين انا ريليف. طيب فهذول التايب اوف بيشنت maybe need admission just to observe البين. لكن جاني بيشنت بسمبل في تي اي ولا بي في تي طيب وهو عمره كويس والكلينيكال بيرفورمانس حقته از جود، سمبلي من الاي ار بليز جيف هيم انتي كواجولانت ابيكسيبان loading dose 10 ملغ بي اي دي for 7 days then maintenance 5 ملغ بي اي دي، قول له روح كمل حجك بالسلامه. مجرد ما اخذ اول حبه من الابيكسيبان هيز انتي كواجوليتد، لا يحتاج له مونيتور ولا يحتاج له اي شيء، وديله انالجيزي عشان الالم حق السنه. طيب بس فيري امبورتنت انك تعرف تنوم مين وما تنوم مين، لانه حرام هذول البيشنت تنومه ممكن تضيع له فريضه الحج. طيب اجين حتى البي اي يو كان ديشارج من الاي ار. لو جاني بيشنت بسمبل بي اي اوكي الاكسجين سات حقه كويس، ما عنده سيفير تاكيكارديا، ما عنده تكيبني. اوكي that's patient simply I can give him anticoagulant send him مع الحج ميشن حقته. طيب ما يحتاج انه انا اعمل دراما مع اي بيشنت تجيني البي اي وانومه واعمل اوكيوبنسي للبيد كاباسيتي اللي عندي. لا، الفي تي سواء بي اي ولا في تي اي الوت خلينا نقول 80 إلى 90% منهم يو كان سند هيم، ما يحتاج تنوم، ما يحتاج كيف ما انت كواجنت من الاي دي وقول له تفضل مع الحرميشن حقتك. طبعا ما تحكي له تمشي، لازم تبين له كمان انه هذا الدواء ممكن يسوي لك بليدنج سيمتوم، ولو صارت لك بليدنج سيمتوم ايش تسوي، وريستريكشن للتروما، وانت بتروح تسوي عمره تتزحلق، وانت بتخش مع زحمه يضربوك. هذه حاجات كلها يو هاف تو اكسبلين في الاخير تهم، ما ادي له الدواء اقول له يلا مع السلامه. اوكي. اي ثينك الهايبرغليسيميا دي كي والهايبوغليسيميا يمكن اخواننا اللي سبقونا يمكن شرحوها، فانا I didn't pass it في my lecture. اخر نقطه حتكلم فيها واخر سلايد الروماتولوجي. كثير بيشنت بيجوكم هو he is already known SLE او روماتويد وبياخذ ميديكيشن. طيب لكن مع الاستريس اللي بيصير في الحج بيخش بفلير، طيب بيصير له ريلابسنج. طيب ممكن يكون لسه الميديكيشن حقته ما جابها انخربت، او مع الاستريس والورك والفيفر والانفكشن اللي ممكن يجيله سيمبلي ممكن يخش في ريلابسنج ويخش في فلير سيمتوم. بس فيري امبورتنت انه كلنا نعرف ايش السيمتوم اللي حتيجي مع الاوتوميون. طيب يعني مثلا لو بيشنت جاني والهيستوري قال لي انا والله اس لي اوكي، وجاني مثلا سيفير ابدومينال بين، ممكن هذه تكون عنصر من الاس ال اي وصل له فليرنج. لو جاني مثلا بانيميا ليكوبينيا ثرومبوسيتوبينيا، لو جاني مثلا باورال ارثر. طيب روماتويد لو مثلا بيشنت جانب سيفير ابدومين يعني عفوا جوينت بين، بيشنت مو قادر يحرك اصابعه، هذه كلها ممكن تكون فلير من الاوريدي اوتوميون ديزيز اللي عنده. طيب هذول البيشنت لو جوني في الاي ار، طيب when I need to admit him when I can send him home. طيب not if يعني طبعا نحن التشالنج في الموضوع ده اجين نفس اللي قلت لكم هو في البدايه، انه انت ما يكون عندك فيري جود ميديكال ريبورت، انت ما تعرف البيشنت ده قبل كده كم ريلابس صار له، ايش اخذ ميديكيشن، ما عندك جود داتا في الموضوع ده. طيب ولكن الجولدن ثيرابي في اي ريلابسنج لاي اوتوميون ديزيز ستيرويد. اوكي فسيمبلي يعني ما هو every relapse I have to admit the patient. طيب حتى لو انا I think انه about طبعا you have to take opinion، لكن انا بقصد اذا انت في اريا ما فيها روماتولوجي اصلا ويو سسبكت انه this patient have flare من autoimmune disease simply just you can give him steroid. طيب and give him medication للاذر symptom، يعني لو كان في بين اديله انالجيزيا. اوكي مثلا لو روماتويد اديله انسيد، اديله بارستامول، لو مثلا عنده جي اي سيمتوم اديله اذر ميديكيشن فور جي اي سيمتوم، وتقول له مثلا ليتر اون بعد ما تخلص فريضه الحج ممكن تتابع مع روماتولوجي او لما ترجع بلادك. اوكي هذا بيريح ناس كثير من ناحيه انه انا نفس الحكايه اللي نقول عليها، بريح البيشنت انه ما بنومه، وبريح الانستتيوشن انه ما بعمل لها بيت كرايسيس كثير. انا حاولت بقدر المستطاع انه اغطي الموست كومون ديزيز اللي ممكن نشوفها في الحج وتكون لها علاقه بالحج سيزون. اوكي اتمنى انه اكون انا وصلت لو معلومه بسيطه يعني ان شاء الله حتى لو اللي فيها بسيطه، ولكن it's very important things simple things we are facing a lot في الحج. بالتوفيق ان شاء الله، وشكرا لكم جميعا.